Good evening, dear students. So, welcome to the session. This is Dr. Rajesh Kaushal taking care of anatomy. Yes, Rakesh, Priyanka, good evening. Rajiv. As we understand, this was NEET PG exam August 2024, and I am very hopeful that whatever you have performed, it was according to your expectations, the hard work which you have put, and all the torment which you have felt, preponement, postponement, but eventually it is over, and we are very much eagerly waiting for the results. The happy news should be with us as earlier possible. So, I will keep on looking at the chat, but mostly my focus will remain on the questions. Worried recording the questions? Yes, that is correct, Shimu, because earlier used to be some 25 questions, now it is 50 because there are 2 sessions, and I do not know, like even I am not well prepared, but we will try to do our best. That is what we are trained for. And so, the very first thing which I am supposed to show you is actually this slide. It is a disclaimer that whatever we are doing here is not authentic as per se, because they are all recall based questions, and we will try to find the options, the stem, as close as possible to the real exam, and we are just trying to get the actual questions. Once we get it, then the final questions will be put on the app. So, this is one of the message, and then the other message is, which I am supposed to show you. We already have recorded the lectures in English. So, rapid revision will be coming not only in English, but also in English, launching on 16th August, and we are very hopeful that not for you, but for your juniors basically, because you definitely will be getting a good rank in this exam and you will be starting with your PG course, but just for the juniors who are coming behind you, they can make use of this, and even you can, like once you join your PG, maybe you are in OBG or derma or radiology, you can go through some of the details, because obviously what I teach is forever. You will definitely be benefited even in your PG course or maybe in your life as a physician or a surgeon, because these things are holistic, they are universal, they will help you all the time. So, as you can see, there are some details, you can go through them, and let us start with the discussion proper. So, as you see, the very first question which I have taken is asking us about the situation for oocyte when it is post ovulation. So, what do you think? It will not be the same way like as I teach. It will go a little bit faster because we do not have time, and you people also, I think you want it to be in a hurried way. But if you want to answer this question post ovulation, the oocyte, let me show you a diagram and then you can decide for yourself. These are some of the details which we continuously read about. So, this is the diagram which we talk about, and as you can see, the very first thing is, it was bot M. What is this bot M, Milind? So, as you understand, when we are talking about the primary oocyte, this primary oocyte is arrested in prophase 1, and prophase 1 also diplotin stage, which is in humans called dictyotin stage. So, primary oocyte will be arrested in prophase 1 till puberty. Our mnemonic is PP1P. PP1P, primary oocyte, is arrested in prophase 1 until puberty, and in prophase 1 also dictyotin, and then at puberty there will be LS surge, and because of LS surge the prophase arrest will be broken and cell will move into the next stage, which is secondary oocyte, but this secondary oocyte will be then arrested in metaphase 2 of meiosis II. You can remember M2F. What is M2F? That the secondary oocyte will be arrested in metaphase 2 until fertilization, and this is the cell which is undergoing ovulation. So secondary oocyte, which is arrested in metaphase 2 of meiosis II, is the one which undergoes ovulation. It is very rare that it will be fertilized because sperms are usually not available. So mostly it will be menstruated. A question comes, which cell is ovulated, which cell is fertilized, which cell is menstruated? You have the same answer. It is the same cell, secondary oocyte arrested in metaphase 2 of meiosis II. This is a cell which is undergoing ovulation, rarely gets fertilized, or mostly it will be menstruated by the end of the cycle. And only if it is fertilized, then you will get what is called as the mature oocyte. So this mature oocyte will be actually fertilized oocyte because the sperm nucleus is already there inside it. So mature oocyte is the fertilized oocyte. Our question was about this stage, and you can go back to your question. Just correct me if I have the proper questions, or if there are any changes in the options, you should tell me. So it is asking post ovulation, and if you say post ovulation, which cell was ovulated? The cell which is ready for the fertilization. So which cell is that? It is the secondary oocyte arrested in metaphase 2 of meiosis II. So secondary oocyte arrested in metaphase 2 of meiosis II, we remember M2F. This is the cell which is undergoing ovulation, will be waiting for fertilization, or otherwise it will be menstruated. So it is the secondary oocyte arrested in metaphase 2. Is that okay? What is fertilized? What is fertilized, what is ovulated, what is menstruated is the same cell which is secondary oocyte arrested in metaphase 2. So I hope I have got the correct question. Maybe there will be some variations in the choices, but then the logic, the concept we should be focusing upon. So I find this question is done. Let us move on to the next one. Okay. Right. So as we move on to the next question, you will see it is asking us about which of the following is preventing polyspermy. So correct me if these are not the options or the stem is different. But sir, it is too tricky. Yes, Milind, I can understand. Actually what happens is you have to work upon the concepts, and you have to continuously revise your facts, and then you have to practice MCQs. That is the only way. Like in all my classes, I always tell that practice as many MCQs as possible and revise and revise. So which of the following prevents polyspermy? Is this the same question, the stem and the options? Kindly tell me. And if this is the question, then before I give you the answer, let me take you through the details, what we usually teach. You see, when the sperm is ejaculated and it already has undergone capacitation, it has reached the ampulla of the fallopian tube for fertilization. So when the sperm has already reached the oocyte level, and that is where it is now undergoing attachment and binding and acrosome reaction. In acrosome reaction, the cap will be lost and acrosin enzyme will be released, so that you can penetrate through the zona pellucida. So very first thing which happens when sperm approaches the oocyte in the ampulla of fallopian tube for fertilization, number one is acrosome reaction. Then it will be penetrating through zona pellucida. As the sperm is penetrating through zona pellucida, it will be fusing with the membrane of oocyte, and the nucleus will be sent inside. So once a single nucleus is inside the sperm nucleus, there occurs number 2 cortical reaction. So number 1 is acrosome reaction, and number 2 is cortical reaction. There will be release of some cortical granules, calcium movement and cortical granules, and because of this cortical reaction, now the ZP3 zona pellucida proteins, they will be changed, and third in sequence will be zona reaction. So the very first thing is acrosome reaction. Number 2 is cortical reaction, release of cortical granules. They will be changing the permeability of the oocyte membrane. And number 3, it is zona reaction. In fact, it is the zonal reaction in mammals, especially the humans, which is preventing polyspermy. So there is a confusion in this question. Should you mark your answer as cortical reaction, which is preventing polyspermy, or should you mark it as zonal reaction, which is preventing polyspermy? According to me, it should be zonal reaction. So what do you think? This was the question. Was this the question, or were the options little bit different? Then we can decide what should we take our answer as. How to subscribe you? Milind, subscription is through PrepLadder app only. I teach only for PrepLadder, and you can go to Android or Apple. There you have PrepLadder app. Through that you can subscribe. There is no individual subscription. It is through PrepLadder only. Physical hardening causing permanent prevention. Sir, previous option was different. It was different. So question was different. What was different? Kindly tell me. Okay, decrease in membrane potential, increase in membrane potential, cortical reaction, acrosome reaction were the option. Okay. There is no zona reaction in the option. Okay. So as you are telling, there is no zona reaction at all. So then what are the options? Kindly see here. Yes, Santosh, I am seeing that. Decrease in membrane potential, increase in membrane potential. Now this becomes more of a physiology question. So what do you think? What have you marked? Because obviously acrosome reaction, cortical reaction is in a sequence. Next should have been zonal reaction. Zonal reaction is something which is changing the membrane potential. Now my physiology is not that sharp that whether it is decreasing the membrane potential or increasing the membrane potential. For this you will have to, these days actually what they do is they will be merging anatomy with physiology, anatomy with pathology, anatomy with surgery, anatomy with ENT, like that. So cortical reaction, you think? I'll have to work upon this question. I have to read some physiology, then what exactly happens to the membrane potential, and then only I can answer, because I am not very sure whether, as you are telling, these options were not there. These options were not there. You are telling either the membrane potential was increased or membrane potential was decreased, and maybe the answer was among that, or maybe the answer was cortical reaction. So I have to work upon this question. Why not acrosome? Acrosome reaction is the sperm which is trying to penetrate. After that you will have cortical reaction, which will then lead to zonal reaction. It is the zonal reaction which prevents the polyspermy. The question is asking what prevents polyspermy. As you go through this, if you say zonal reaction, what is zonal reaction doing? Zonal reaction is just when this acrosome reaction is just when this sperm is trying to penetrate. So that is not preventing polyspermy, that is the initial process of sperm going inside. So once the acrosome reaction is there, after that there is a cortical reaction, and after that there is a zonal reaction. Zonal reaction may be, I don't know, it is increasing the membrane potential or decreasing the membrane potential, that I will have to find out, but I believe the answer will be somewhere there. What do you think? More of physiology question, yes, I understand. Membrane hardening. Okay, let me work upon this question, and we should not spend much time here, but this is the concept actually, and then from anatomy it is moving on to, from embryology it is moving on to physiology. So I will have to work upon that, and so for the time being what we will do is we will keep a query here. Acrosome reaction, cortical reaction, after that zonal reaction, if it was there I would have taken as the answer, but it was not there. Then we have to look at whether the membrane potential is increased or decreased, that will prevent polyspermy. So still it is undone. Yes, that's what. So give me some time, I will work upon this. Now as we move on to the next question, implantation occurs which day post fertilization? What do you think is your answer? Is this are there any repeats from July FMGE? Yes, there are some questions which came from July FMGE. There are, like posterior tibial artery palpation, I believe. Nowadays there are so many exams continuously we go through that we forget that in which exam which type of questions came. It all gets mingled up. But I keep a register, I can find out. So was this the question, implantation occurs on which day post fertilization? Before I answer this question, let me show the slide which we normally use. This is the slide and it is a controversial question, take it from me, but I think answer won't be like we can quickly find our answer. What happens is, you have to understand some concept here. The ovary is undergoing ovulation. As we understand, the cell which is ovulated is secondary oocyte, which is M2F. It is in metaphase 2 until fertilization occurs. This was also a question. So ovary undergoing ovulation, it will give us the secondary oocyte which will be arrested in metaphase 2 of meiosis 2, and this is the one which is undergoing fertilization. So when there is fertilization, it is on the same day of ovulation. The fertilization should occur within 12 to 24 hours of ovulation, means day 1 when we were having the ovulation, on the same day we are having the fertilization. Day 1 is ovulation and also fertilization, because fertilization should occur within 24 hours of ovulation in the ampulla of fallopian tube. Now day 1 you have single cell which is zygote. Now day 1 you have single cell which is zygote, day 2 you will have 2 cell stage. So day 2 you will have 2 cell stage, and day 3 you will have morula, which we normally take as 16 cell stage. So day 1 single cell stage which is zygote, day 2 it is 2 cell stage, day 3 it is 16 cell stage, but remember that the 16 cell morula can become more than that also, because the one which enters the uterine cavity is day 4, this is called advanced morula, and this advanced morula which has entered the uterine cavity on day number 4 is about more than 32 cell, in fact more than 32 cell stage, it could be even 58 cell stage. Different authors, different answers. So these are all MCQs, all of these are MCQs. So the cell, the structure which enters the uterine cavity on day number 4 is advanced morula. It is more than 32 cell, could be 58 cell also. Day number 4, by the end of day number 4, it will lose the zona pellucida. So by end of day number 4 it will lose the zona pellucida, and it is day number 5 that it will be starting the implantation. Implantation is a week-long process. It is a week-long process. It begins on day number 5, completed on day number 12. So if somebody asks implantation, you say it begins on day number 5 when zona pellucida was lost, and it is ending at day number 12. But they don't ask you this range. They ask you, is the implantation beginning on day number 5? You say yes, of course. Then it is completed in, the options could be, sometimes they give you options like 5 to 7, 7 to 9, 9 to 12, and that is what creates controversy. That is what which creates controversy. In this also, if you look at the Guyton keep on changing the answer. So as such the range is 5 to 12, but we are not going to those details, those controversies. You can come back to your question and you can find your answer. Question is asking, implantation is occurring which day post fertilization? Now whether you say post fertilization or you say post ovulation doesn't matter, because the fertilization occurs on the same day as ovulation. It is the same thing. So day number 5, yes, day number 5 should be your answer. Actually it should be 5 to 12. But if you say it is 5 to 12, that will create a problem here. But it is telling implantation occurs on which day. I am telling you it is not a simple question. OBG people give different answer, embryology people give different answer, the radiology people give different answer, and I am the one who read OBG, radiology and embryology, all the books. So I will be the best person to give you the best possible answer. Best possible answer is 5 to 12, but it is not given. So I will go for day number 5, because implantation occurs, it begins, and this will be my answer. Otherwise it will be a problem. Sir, it was different. Okay, so what was different? Difference between position 2 and position implantation, right. So, if you want to see the difference between position 2, that is day number 1, and implantation, that is day number 5, you want to, is this a mathematical calculation? Was that a mathematical calculation? This question is mysterious. Yeah, now it appears to be. 5th day zona hatching, post 6th day implantation. No, implantation begins on day number 5. Take it from me. I have hundreds of books with me as a reference. You just stick to what I am telling. Yeah, maybe it was straightforward and we are overthinking. Implantation window is day number 5 to 12. Implantation window is 5 to 12, begins on day number 5 according to Keith Moore embryology. Day number 5 it begins. It was simply asked that number 2 to number 5, which is implantation, how many days? If you say from the fertilization to the implantation, the gap if you want, then it will be 4 to 5 days, 4 to 5 days. But what were the options then? The difference, if they have asked the difference, means it is mathematical calculation. And if you are talking about mathematical calculation, I will take you back to this diagram. Say if they are asking you that whenever the fertilization or ovulation is occurring, that is, let us take it as point A in time, and when implantation is happening, point B in time. So, point A is day 1, take it as day 1 as reference point, and this is day number 5. You can say 6 because you see here according to Langman embryology 5.5 to 6 days, actually it is day number 5. So, if it is day number 1 and that is day number 5, what is the difference? 4 days, 4 to 5 days, that should be your answer. Okay, diagram was 1, maybe 1, 2, 3, 4. Maybe in the diagram it was written as 1 is ovulation, 2 is fertilization, 3 is when it enters, and 4 when it is implanting. Maybe that was 1, 2, 3, 4. Okay, so in the option it is 6, not 5. That means we have to change the options. So, what were the options then? Can you tell me if the options were different, what were the options? That is a tragedy actually. Some of us will remember, some of us will not remember, but I go through a lot of your friends, ask questions from them, and then they give us the feedback. According to feedback we prepare the questions, and it is a stringent process, but still we can make mistakes. But I believe that it should be choice number B and it should be the answer. Okay. So, maybe the concept I have discussed, and we can move on to the next question. The next question which we have got is fracture at which site affects the longitudinal growth of the bone. You have to tell me whether the question was there or was there any different kind of framing, different options. Yes, Anishu, that is what we have to do. We have to move on. Okay, so this was the question, fine. Now the thing is, to make you a little bit more comfortable with this description, what you find is that in the beginning we will have a hyaline cartilage model. In the beginning it is all hyaline cartilage model, then some blood vessel will come, that blood vessel will bring primary center of ossification, some bone will start forming, and then this will be week number 6 intrauterine life. So, week number 6 intrauterine life, one blood vessel will come, bring some primary center of ossification, some osteocytes and all that. Now, the second stage is say you are having this bone here, now baby is born, that means after birth. So after birth, if you look at that, let me take some other color, green color. So after birth, what we will find is that this primary center of ossification, it would have formed the diaphysis or the shaft, whereas after birth another blood vessel will come, and that blood vessel which comes is at both the ends, it will be forming secondary center of ossification, and that secondary center of ossification later it will become what is called as the epiphysis. So that will be epiphysis, this region is going to be the epiphysis, one epiphysis or maybe more than that. So the secondary center of ossifications, they appear after birth and there will be epiphysis, but then some hyaline cartilage will persist, and that hyaline cartilage which is persisting, let us use this color here, that will be the growth plate. This is the growth plate. So this is the growth plate, or you can call it as epiphyseal plate. So growth plate, epiphyseal plate, still it is hyaline cartilage, and this is the one which will help us in growing the bone. Now this growth plate which is helping us in growing the length of the bone, if a fracture happens at that point in a young child, maybe below the age of 18 years, if that growth plate is compromised, then there will be a problem with the lengthening of the bone, and maybe that was the question. So fracture at which site? The longitudinal growth of a bone, longitudinal growth like the humerus bone. If you have a fracture at the epiphyseal plate, definitely there will be a problem with the lengthening of the bone, and that should be my answer. If you are talking about diaphysis, it is here. If you are talking about epiphysis, at the end, and this growth plate, whichever bone it forms, that area is called as the metaphysis. So metaphysis is the epiphyseal end of diaphysis. That is how we say. If somebody asks you what is metaphysis, metaphysis is the epiphyseal end of diaphysis. It is a diaphysis only which has one end, and that is metaphysis. So metaphysis, look at the definition. Metaphysis is the epiphyseal end of the diaphysis. And how did you form metaphysis? That metaphysis is formed by the growth plate. As it keeps on adding, the cartilage keep changing into bone, which is called as ossification. So there will be some zone of calcification, zone of ossification, all that. So what do you think? Hardly 50 are watching. Maybe hardly 50 are watching, but these videos, the students, they get tired, they sleep, they'll come in the morning and they keep watching. They keep it watching for next 5 years. These videos are never downloaded, they are always there, and they will be helping the students later. Maybe I have a tendency that even if one person is watching or nobody is watching, I'll do my job with sincerity. Don't trust on RR, rapid revision. If you are talking about rapid revision of anatomy, you can trust, because I do it very sincerely. But take it from me that rapid revision is a rapid revision. You have to go through the main videos. You cannot understand rapid revision, and in rapid revision we cannot complete everything. So rapid revision is a good thing, but only if you have done your main videos. You cannot just depend upon rapid revision and think that you are ready for the exam. That is not possible. That is what I try to tell the students. Sometimes they understand, sometimes they don't. Okay, so हाँ शर्ट, अच्छा शर्ट को देखो, पोनी को देखो, अरे भाई पढ़ाई करो, अच्छे डॉक्टर बनो, ये सब तो सेकेंडरी है, ये सब आप भी बाद में कर लेना, अच्छी अच्छी शर्ट आप पहन लेना, अभी पहले पीजी की सीट ले लो. चलिए ठीक है. So we are moving on to this question. So just tell me, was this question there, and if any changes in the options are there. Identify the markers in the given slide, and they were marking acrine gland, erector pylorem, sebaceous and apocrine sweat gland. So was this question there? सॉन्ग आपको सुनना है तो मैंने अभी अभी एक लेटेस्ट यूट्यूब पे अपलोड किया है, उसे आप सुन लीजिएगा बाद में, लेकिन अभी अभी हम ये डिस्कशन करेंगे. The image was different. Okay. Let me show you another image. So this is a schematic diagram, that is a histology specimen, and what we have to understand is that this is a specimen taken from the skin with hair follicle. So you can see the hair follicles, these are the hair follicles, and here is the hair follicle. This is one of the hair follicle. Along with the hair follicle you will have this sebaceous gland. So C marker is sebaceous gland, because sebaceous gland is a holocrine gland. Sebaceous gland is a holocrine gland, entire cell is broken and forming the sebum. Along with that hair follicle, it will go and it will lubricate the hair follicle. That is one thing. Second thing is, you have to understand that along with hair follicle there are some other glands also which are sweat gland, and if you are at a deeper level, if you compare like D will be the apocrine variety of sweat gland, which will again open into the hair follicle only. But if you are looking at this marker A here, this will be the acrine variety, which opens directly on the skin surface. So you have to be a little bit careful about the explanation here. This is marker A, which is opening directly on the surface. This is acrine. Now if that is acrine and you are telling that D is the apocrine, how do you know that one is apocrine sweat gland and the other is the acrine sweat gland? There are many methods. One is apocrine is deeper and the acrine is superficial. You can see here on this side, acrine sweat glands are superficial and apocrine sweat glands are deeper, first of all. So deeper and superficial when you are looking at the thickness of the dermis. Number 2, you will see that the acrine glands, they are opening directly on the surface. They open directly on the surface, you see here, and they have watery secretion. They have watery secretion, thin watery secretion. But if you compare it with the apocrine now, apocrine, first of all, they are deeper, as you can see, compare the two, and they open into the shaft of the follicle. And as they open into the shaft of the follicle, you will find that the secretion which they are giving is thick and viscous, and these apocrine sweat glands are very few. You will find them only at places where you have hair, like axilla, perigenital area, or even around the nipple. So apocrine glands are very rarely found glands as compared with acrine. Acrine, like most best example is hand and feet, the palm and sole. And if you are talking about apocrine sweat glands, they are having thick viscous secretions, go along with the hair follicle. They are in the axilla, perigenital area. So a lot of things are there. Now the thing is, what was our answer? That is the point. And what is this marker B? This marker B is the muscle which is the erector pylorem. Erector pylorem, which will be helping us to erect the hair under sympathetic system. So under sympathetic system, you know, when there is fight or fright or flight, you will see the erection of the hair follicle, and that is erector pylorem. So I think this was the question. What do you think? Was this the same type of question or different? Erector pili was also there, yes. Habit muscle we will discuss. पेपर नहीं दिया सर अभिषेक, कोई बात नहीं, बाद में जब भी दोगे तो तैयारी हो रही है तुम्हारी. So I think this is the marker, and I already have given you a marker. If you are asking for the marker A, it is superficial, so acrine. Marker B, it is the muscle, erector pylorem. Marker C, it is a sebaceous gland. And if you are talking about marker D, the deeper glands, it is apocrine sweat gland. Somehow, because I have been watching this system for last 20 years, we get an idea. Just watch my last resort revision LRR, and I was very much telling you that they are going to ask you difference between acrine and apocrine, and it happened. Anyway, yes, hybrid was obturator, that is correct. So, okay, let us continue, and then as you see, this is one other question. A neonate presented with failure to pass the meconium. Let me wear the glove because this touch screen will have problems, so I will have this gloves. A neonate has presented failure to pass meconium, so it gives you the idea of Hirschsprung disease, the structure absent in pathology, which of the following layers. Now be careful, the examiner what he does is, one time he will ask you something and some students will mug up the answer, next time they will make a mistake. So of course we are talking about Hirschsprung disease, which is congenital aganglionic megacolon, congenital since birth, aganglionic no ganglia, and megacolon the colon becomes larger. So it is a problem of neural crest cells. Neural crest cells, they are not migrating properly, especially to distal colon. So if neural crest cells are not migrating properly to distal colon, it is the neural crest cells which form ganglia, and you won't have ganglia in the distal colon. And ganglia which are there in the distal colon are parasympathetic, and these parasympathetic ganglia are basically for evacuation. How do you do evacuation? By increasing peristalsis and relaxing the sphincter. I will repeat the things again. What is Hirschsprung disease? Congenital since birth, aganglionic no ganglia, megacolon big colon. How do you know it is aganglionic? Because I took a rectal biopsy. In rectal biopsy there are no ganglia, aganglionic. Okay, so neural crest cells, they form ganglia. Yes, neural crest cells form peripheral nervous system, they form ganglia. And where the ganglia are missing? In the distal colon. So in the distal colon, which ganglia are missing? The parasympathetic. Okay, if parasympathetic system is missing, what is it for? Parasympathetic system is for evacuation, bladder bowel evacuation, by increasing the peristalsis and relaxing the sphincter, fecal meconium out. But if it is not there, you cannot send the meconium out. So which ganglia are missing? If you have to give one answer, if you have to give only one answer, then I will tell you that one answer should be Auerbach's ganglia, Auerbach's. And if you have to give two, then you should say Meissner's. Now Auerbach's ganglia is in the muscle layer and Meissner ganglia is in the submucosa. The Auerbach's ganglia which is in the muscle layer is for increasing the peristalsis, and the Meissner ganglia which is in the submucosa is to increase the secretions. Basically parasympathetic system increases the glandular secretion, that you know. So if the question comes, what should I answer, Auerbach's or Meissner? Both. But if I have to choose one, then Auerbach is preferred over Meissner. But anyway, here they are asking both of them. So where are they? For that you have to understand, if this is colon, if this is colon, then this is the number A. What is number A? Number A is the mucosa, and mucosa also basically it is epithelium and subepithelial connective tissue and muscularis mucosa. So this is together called as mucosa. What is A? A is the three component, that is the mucosal epithelium, subepithelial connective tissue and the smooth muscle muscularis mucosa. Okay, that is A. Then what is B? As you look at B, it is under mucosa, so you will call it as submucosa. So this is submucosa, and in the submucosa you will have the Meissner plexus. So in your answer you should have B marker. Okay, then what is this here? Inner circular, outer longitudinal. Inner circular, outer longitudinal, and abutted is Auerbach's. Abutted is Auerbach's. What is this abutted? Abutted, like a sandwich. So which ganglia will be here in the muscular layer? That is the Auerbach's. So here you will have the Auerbach's, and there you will have the Meissner. And then what is D? D is the serosa, and there you have peritoneum, and some neurovascular bundle is also there. So some neurovascular bundle is there, that is the serosa, but our focus is on the muscle layer, abutted, the Auerbach's, and Meissner, that is in the submucosa. So you mean to say B and C? Yes, B and C, that should be our answer. Our answer should be B and C. Now we have two of them, but anyway, the option should have this B and C, both of them. So what do you think? Is it okay now? Daksh, my MBBS is from Bangalore Medical College, batch is 93. 93 batch, Government Medical College, Bangalore, All India PMPD exam, year 93, secured some rank 1500 something. BMC was the 10th in position. Number 1 is always AIMS, Delhi. No, it cannot be BCD, cannot be BCD. It should be B, marker B and marker C, the Meissner and the airbags. Now maybe sometimes there are clerical errors, like you can see BC, BC is written here, but you have to, don't bother about this clerical errors, you have to focus upon the concept. हाँ, ये हो सकता है कि आपको याद नहीं आ रहा तो मॉर्निंग शिफ्ट में हो सकता है, वो ठीक है, वो तो हम एग्री कर लेंगे. अब यहाँ बताओ इसका आंसर क्या है? ओके, सो टंग का पेपिला की बात हो रही है एंड यू कैन सी दैट there are some details which we have to find out. You see, the most populous taste buds are basically filiform. Filiform means very sharp, needle like, and they don't have taste buds. So most numerous are filiform and they don't have taste buds, and they have keratin. They have keratin. Normally taste buds will not be having keratin, but these filiform papilla, they are numerous and they will be having keratin, and their purpose is not to receive taste, their purpose is to feel for the texture, the consistency of the food, and give some resistance to the food. Food should not slip basically. So the filiform papillae, they don't have taste buds, they have keratin. Normally taste buds will not have keratin, because if you have keratin then how will you take the taste? So these filiform, they are keratinized, they are sharp, they have they give resistance to food, and they help us to feel for the texture and consistency of the food. Otherwise, if you are talking about fungiform, like a fungus, it is fungiform papilla, they do have taste bud. Then there is this foliate. Foliate are very rare, they are mostly in children, otherwise they are rudimentary, and foliate, they will have some vertical ridges here. So first of all, they are very rare. We humans don't have foliate papilla well developed. Maybe in children it might be there, and there are very few in number. And then the one which is there and which is important, which is in relation to the sulcus terminalis, in front of that, that is the circumvallate papilla, and circumvallate means circular valley, circumvallate. So they will have a circular valley around them, like in a circular fashion, like you can see circular valley, and they are basically in front of the sulcus terminalis, circumvallate papilla. They definitely will have taste buds, especially on the sides, in the valley. In the valley some taste liquid will come and they can detect that. So all of them will have taste buds, but not the filiform, and that is our answer. So I hope this is the question they have asked. Fastigial, Runken gate, all that we will discuss. जो मैं पढ़ा रहा हूँ उसको छोड़कर इधर उधर भाग रहे हो. Attention deficit ADHD. पहुंचेंगे वहाँ, सेरिबेलम तक पहुंचेंगे, चिंता मत करो. Which type of tongue papilla lacks taste bud? तो यहाँ पर हमने बोला filiform. ठीक है, ये आंसर हो गया आपका. चलें आगे. मुझे भी है ADHD, मुझे भी है, सारे डॉक्टर्स को अगर नहीं भी होती होगी तो हो जाती है। अटेंशन डेफिसिट हो जाता है और हाइपर एक्टिविटी डिसऑर्डर हम सबको ही होता है। देखो भाई, एक OPD में बैठे हो, 200 पेशेंट आए हुए हैं, क्या करोगे? हम तो गवर्नमेंट सेक्टर से निकले हुए हैं, बोरिंग हॉस्पिटल में मेडिसिन का डिपार्टमेंट है, अक्सर लोग आते हैं हाथा पावा दर्दा लेके, तो उनको तो क्या लिखोगे, बोवेरॉनी लिखोगे, मल्टीविटामिन लिखोगे। तो जल्दी 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 आपको जब करना है तो अटेंशन डेफिसिट हो जाएगा और हाइपर एक्टिविटी डिसऑर्डर ऑटोमेटिकली हो जाएगा। 200 पेशेंट निकालने 2 घंटे आपके पास, समझ में आया? तो आप क्या करोगे? रोटंडम था या सुपीरियर ऑर्बिटल फिशर था? ओके, अब यहां बताओ, इसका आंसर बताओ। इतना ज़्यादा ADHD मत करो यार, जो सामने दिख रहा है उसको तो, जो सामने पेशेंट है उसको तो देख लो। उधर 25वां पेशेंट पे नज़र तुम्हारी कि वो उधर खड़ा है, उसको देख रहा हूँ। आएंगे हम वहाँ पर अभी। फॉर्मन रोटंडम जो भी था। ओके, सो टॉसिस की बात कर रहे हैं। अब ये बताओ कि ऑप्शन ये थे कि नहीं थे? हॉर्नर सिंड्रोम, पैरालिसिस ऑफ विच मसल, ये ऑप्शन थे या नहीं थे? या कि कोई कह रहा है कि मिलर मसल था। मिलर था तो ठीक है, फिर तो कोई दिक्कत ही नहीं, फिर तो ये आसान हो गया। सुपीरियर टार्सल मसल जो है, देखो मिलर मसल जो है ना, ये ध्यान रखना, मिलर मसल के बहुत सारे पार्ट्स होते हैं। मिलर मसल के बहुत सारे पार्ट्स होते हैं। मिलर मसल एक वेग टर्म है, मिलर मसल टर्म यूज नहीं होनी चाहिए। यहाँ पर जो आंसर होना चाहिए सुपीरियर टार्सल मसल होना चाहिए, जिसकी सप्लाई जो है वो हॉर्नर सिंड्रोम, मतलब T1 सिंपैथेटिक, T1 sympathetic. So you have a problem with T1 sympathetic pathway, and because T1 sympathetic pathway is supplying the superior tarsal muscle, orbitalis muscle, that is why you are having problem. Because superior tarsal muscle is a part of the elevating the lid, there will be a partial ptosis. मैं आपको एक डायग्राम दिखा देता हूँ, उसको देख कर फिर आप बात करें। ये डायग्राम मेरे ख्याल से हमारे इस वाले पेज पर है। तो ये है हमारा हॉर्नर सिंड्रोम का पेशेंट। और हॉर्नर सिंड्रोम वैसे तो बहुत रेयर है, आप अपनी ज़िंदगी में हो सकता है कभी देखो ना, लेकिन एग्जामिनेशन में रेयर नहीं है, एग्जामिनेशन बहुत बार आता है। सो यहाँ पर क्या है, कहाँ पर दिक्कत है? यू कैन सी वन थिंग क्लियरली इन दिस डायग्राम, दैट दिस आई, इफ यू लुक एट दिस आई, यू आर सीइंग देयर इज अ पार्शियल टॉसिस। यहाँ पर पार्शियल टॉसिस है, उसको कंपेयर करो इस वाली आई से, ये नॉर्मल आई है, वो नॉर्मल आई है, लेफ्ट वाली, राइट में पार्शियल टॉसिस है। क्यों है? सुपीरियर टार्सल मसल विच इज अ पार्ट ऑफ मिलर मसल इज कॉम्प्रोमाइज्ड एंड दे आर सप्लाइड बाय T1 सिंपैथेटिक फाइबर। सो T1 सिंपैथेटिक का प्रॉब्लम है, मिलर मसल का प्रॉब्लम है। मिलर मसल के बहुत सारे पार्ट्स होते हैं, उनमें से एक जो है, वन इज द superior tarsal muscle, and that is why there is a partial ptosis. But the Miller muscle has one more component, and that component of Miller muscle is called as orbitalis. It is a muscle in the orbit, and that orbitalis slightly pushes the eyeball out. It's a smooth muscle, they are all smooth muscle, because sympathetic system, it will control only smooth muscles basically. So T1 sympathetic also supplies orbitalis. Orbitalis is a muscle in the orbit, will push the eyeball out. But now it is not working, and if orbitalis is not working, there will be a sunken eyeball, and when you say sunken eyeball, it is what you call as enophthalmos. Enophthalmos. These are all questions which keep coming again and again in last 15 to 20 years. Now normally faculty will tell just to do last 5-year questions and you will be selected. I am totally against it. It is not like that. You have to do last 15 to 20 year questions, because questions keep repeating from there. You cannot be getting a rank by just doing last 5-year questions. But anyway, people will not listen to me because I am old school person, and whether you listen to me or not listen, but I'll do my job the way I do. So there is this orbitalis which is a part of Miller, and if it is compromised, then there will be a sunken eyeball which is called enophthalmos. But along with that, T1 sympathetic fiber, they also supply some other muscles, like which one? Sphincter pupillae is becoming more powerful. Why sphincter pupillae is becoming more powerful? Because dilator pupillae is compromised. You can look at the pupil now. As you look at the size of the pupil, you will notice that this is meiosis. Why? Because sphincter pupillae became more powerful. But why sphincter pupillae became more powerful? Compare it with the normal pupil. That is normal pupil, left pupil. Right pupil is showing meiosis. Why? Why sphincter pupillae is more powerful? Because one muscle which is supplied by T1 sympathetic, that is called as the dilator pupillae, is also compromised. And there are other things also in Horner syndrome. We are not going into much detail, but this baby is having, this is congenital Horner syndrome. This is a case of congenital Horner syndrome because the baby, and there is a partial ptosis, superior tarsal muscle, part of Miller is compromised. That was your question, I believe, and let us go back and put our answer there. So it is asking ptosis in Horner syndrome and paralysis of which muscle? You should say superior tarsal muscle. If not given, then you say Miller muscle. But be careful, because Miller muscle also should include orbitalis. This together is Miller muscle. Be careful about it. Orbicularis oculi is to shut the eyelid. Basically, sphincter pupillae is actually becoming more powerful. In this case, it has become more powerful because in Horner syndrome, dilator is not working. Levator palpebrae superior was also given. Okay, if levator palpebrae superior was given, LPS is a skeletal muscle for elevating the eyelid. LPS is a skeletal muscle for elevating the eyelid supplied by oculomotor nerve, and oculomotor nerve will have no problem in Horner syndrome. Oculomotor nerve, it is levator palpebrae superior and it is oculomotor nerve. It is a skeletal muscle, and the skeletal muscle is not having problem in Horner syndrome. Horner syndrome is a problem with sympathetic system. It's smooth muscles which are affected. मिलर गुबलर है, हम डिस्कस करेंगे मिलर गुबलर सिंड्रोम को भी. Okay, now we have this absent gag reflex. Absent gag reflex. To understand this, let us just look at this diagram. You take one tongue depressor or maybe ice cream stick, and that ice cream stick you are going to touch the oropharyngeal isthmus. Oropharyngeal isthmus means where the oral cavity becomes pharynx. You can touch the posterior 1/3 of tongue, you can touch the posterior 1/3 of tongue, or you can touch the tonsil, or you can touch the uvula, because all of them are supplied by glossopharyngeal nerve, gag reflex. Or you could touch the posterior pharynx wall, or you could touch the posterior pharynx wall. That is gag reflex. You want to do gag reflex, you take one tongue depressor and touch the posterior 1/3 of tongue, or the tonsil, or the uvula, or posterior pharyngeal wall. What will happen? It is called gag reflex. But why do you need a gag reflex? You don't want unnecessary things to enter your respiratory tube or gut tube, you can say. So both the tubes you want to, there will be a sudden spasm of some muscles. So which muscles will be undergoing spasm? Palate, pharynx and larynx muscle, especially palate and pharynx muscle. They undergo sudden violent spasm. And why is spasm? Because they are trying to close the aerodigestive tract, that not everything should go in. So it is a protective reflex. You don't want everything to enter your aerodigestive tract, so just stop it. So that is what is called gag reflex. But how does it work? You have sensory nerve, 9th nerve. Now if you have the sensory nerve, 9th nerve, where will it take the information? The 9th nerve will take this information to a sensory nucleus. Which sensory nucleus? It is the nucleus tractus solitarius. So it will take this information to nucleus tractus solitarius, and from there, it is a sensory nucleus, it will activate the motor nucleus. So which motor nucleus will be activated? It is called nucleus ambiguous, which will have number 9, 10 and cranial part of 11. So 9th nerve is sensory, which is bringing information, arrival. Now if you say it is bringing information which is arrival, arrival means it is afferent, A for arrival, A for afferent towards the CNS, and from there nucleus ambiguous, and then you will have efferent. Efferent means exit. So efferent means exit, E for efferent, E for exit. So which is the efferent nerve? Efferent nerve is vagus accessory complex. Actually 9, 10, 11 all of them, nucleus ambiguous, the motor nucleus. So what is this nerve number 9, 10 and cranial part of 11? what are they doing in nucleus ambiguous? They are the one which control the muscles of palate, pharynx and larynx. So the muscles of palate, pharynx and larynx, what do they do? Speech and swallowing. They do speech and swallowing. Again, when you touch the posterior one third of tongue or oropharyngeal isthmus, what happens? Ninth nerve is activated, which is sensory, and it is afferent. And what does it activate? Nucleus tractus solitarius, which is in the medulla oblongata, lateral medulla, and then it will activate nucleus ambiguous, which is also in the lateral medulla. Okay, so nucleus ambiguous is constituted by which nerves? Motor nerve, 9, 10 and cranial part of 11. What do? They control muscles of palate, pharynx and larynx. What do the muscle do? They are for speech and swallowing. That is why there was a sudden spasm, and you don't want unnecessary things to just enter your aerodigestive tract. So as you come back, you can understand sensory motor nerve, and that is what the question is asking. And absent gag reflex result from injury to which nerve? 9 and 10. 9 is sensory and 10 is motor. Now be careful, it is a game of chess. What you play with the examiner or what the examiner plays with you, it is a game of chess. What is this game of chess? You know, sometime one question will be asked and students will mug up the answer. Next time they will add some detail. So let me add the detail. You should know one step ahead of the examiner. Examiner will always be one step ahead of you. So if you want to beat the examiner, you have to be 2 steps ahead of the examiner. Well, how do I do that? You practice more and more of MCQs, and what I am trying to tell you here is not only 9th nerve is carrying the information in gag reflex, it is trigeminal also, 5th nerve. So 5th nerve is additional, and it also carries the information of gag reflex. Just keep that with your the information should be with you, because it has been seen. In 9th nerve injury, gag reflex is still working. How come? In some patients it is seen that despite the 9th nerve was compromised, still gag reflex was working. How come? Because still the 5th nerve was intact. So 5th and 10th nerve, yes. 5th nerve takes the information to the CNS and 10th nerve brings it back and gag reflex is working. So be careful, though your answer is 9 and 10, of course, but in 9th nerve injury still it has been seen gag reflex was still working, paradoxical gag reflex we call it as. So if the 5th nerve is still letting you do the gag reflex, which is obviously is there clinically, so we will say paradoxical gag reflex. So this is some additional information, as I am telling you that examiner plays the game of chess with you people, and if you want to beat the examiner at his own game, you should be 2 steps ahead of the examiner. Thinner eminence, nice hairstyle. How the hairstyle will help you to get a PG seat, man? After you get your PG seat, then you keep your hairstyle, no problem. Okay, what about this? Tell me, a singer first of all, present with singing at high pitch, presents with difficulty, there is a difficulty in singing at high pitch. There is a bowing means it is not tense, tension is gone. Right side, which of the following muscle? Which is the only tensor of vocal cord? The only tensor of vocal cord is cricothyroid muscle, which is powerful, though it is assisted by anterior part of thyroarytenoid also. So this is a singer who is singing, like you know, in singing there is sa re ga ma pa dha ni sa, that sa is high pitch, that he cannot do. Why he cannot do? Because maybe the external laryngeal nerve, branch of superior laryngeal nerve is compromised while doing thyroidectomy. You were doing thyroidectomy, you are not careful, you have damaged external laryngeal nerve which runs with superior laryngeal artery maybe. So if you are not careful while removing thyroid gland, You have damaged the external laryngeal nerve, which is a branch of superior laryngeal nerve. Both of them belong to arch number, they are arch number 4. This muscle is the only muscle which develop in arch number 4, cricothyroid muscle. So arch number 4, you have only one larynx muscle, which is cricothyroid muscle, and it is supplied by nerve of arch number 4. Who is the nerve of arch number 4? Superior laryngeal nerve. Superior laryngeal nerve give you which branch? The external laryngeal nerve. And external laryngeal nerve, if you damage the external laryngeal nerve branch of superior laryngeal nerve, then you will paralyze the cricothyroid muscle. There will be a problem with the tension of the vocal cord. Vocal cord should be like this, and if it is like this, bowing. If it is bowing, means it is not getting tensed. And why it is not getting tense? Because the tensor is not working. Your answer is cricothyroid. And if cricothyroid is not given, then you should say anterior part of thyroarytenoid. Remember, posterior part of thyroarytenoid is a relaxer of vocal cord. Posterior part of thyroarytenoid is a relaxer of vocal cord, whereas anterior part is a tensor working along with cricothyroid. But among the two, cricothyroid is a better answer. So in this question, your answer should be choice number C. That is what you should give your answer. Now tell me, were there any different options? How to start PG preparation from third year MBBS? Third year MBBS, just do your university course, whatever your teachers are teaching you in the classroom. Go to your clinics and read your Harrison and Bailey Love and Datta, OBG, whatever you do, do it. Just take 1 hour out of your curriculum and start watching or doing MCQs, multiple choice questions. And those MCQs will give you the idea that what kind of questions you are going to get in your entrance exam. That is the way. So 1 or 2 hours per day. 1 hour is okay in third year MBBS, if you are asking me third year. And if you have time, then you can start watching videos also. The faculty who is teaching, and there are numerous apps. Because I work with PrepLadder, I'll say PrepLadder app, and like Dr. Marwa teaching you medicine, then Dr. Pritesh teaching you surgery, then Dr. Viz teaching you OBG. Just spend 1 hour per day on these lectures and start doing some MCQs. That is the way. If I was there, I will do it myself. If my son is doing MBBS, I'll tell him to do this one. So you are like, I am your father figure, you are my son and daughters. I have a lot of them throughout the country now. And as a sincere parent, teacher, your senior, your guide, I'll tell you whatever I'll tell to myself or my own son. Never read Harrison. कौन है भाई? रिंकू दास. क्योंकि क्या मारवा सर ने पढ़ लिया और आपको उसमें से पढ़ा रहे हैं? देखो, हैरिसन से बढ़िया किताब आपको कोई किताब मत पढ़ो, लेकिन हैरिसन जरूर पढ़ो. अब आप बोलोगे सर पढ़ी नहीं जाती, नींद आती है. आपको ये नहीं पता होगा कि 25% क्वेश्चन एनाटॉमी में हैरिसन से आते हैं. 25%, 25% क्वेश्चंस ग्रेज एनाटॉमी से नहीं, हैरिसन मेडिसिन से आते हैं. नहीं पढ़ना चाहते हो मत पढ़ो, कोई बात नहीं, मगर मैं तो कहूँगा कि हैरिसन, सारे MBBS में कोई और किताब पढ़ो ना पढ़ो, लेकिन हैरिसन जरूर पढ़ो, पेज टू पेज. एक अच्छे डॉक्टर बनोगे. हमारा पर्पज़ ये थोड़ी नहीं है कि आपको सिर्फ डॉक्टर बनाना है. हमारा पर्पज़ है आपको अच्छा डॉक्टर बनाना है. अच्छा डॉक्टर बनने के लिए आपको हैरिसन पढ़नी चाहिए. भले ही मारवा सर आपको पढ़ा रहे हैं, वो भी हैरिसन से पढ़ाते हैं. कहाँ से पढ़ाते हैं? वो भी तो हैरिसन से ही पढ़ाते हैं. उनको सुन के पढ़ लो. हैरिसन, हैरिसन एक किताब है जो आपको ज़रूर पढ़नी चाहिए. लिख दिया ना मयंक, मारवा सर हैं तो क्यों पढ़े हैरिसन? ठीक है भाई, ठीक है. ओके, टेल मी व्हाट अबाउट दिस क्वेश्चन. किताब पढ़ने का एक अलग ही फायदा होता है, फोटोग्राफिक मेमोरी बनती है. चलो खैर ये छोड़ो, बाद में कभी बात करेंगे. टेल मी, स्लिप डिस्क एट द फॉलोइंग लेवल लीड्स टू इन्वॉल्वमेंट ऑफ विच रूट वैल्यू. पहले तो स्लिप डिस्क है कहाँ पर? देखो ये है सैक्रम, यहाँ तो सैक्रम शुरू हो गया. ठीक है, ये सैक्रम शुरू हो गया तो ये कौन सी वैल्यू हुई? ये यहाँ पर हो गई L5. ये L5 है तो L4 हो गया. इनके बीच में देखो ये पोस्टेरोलैटरल हर्निएशन हो गया है डिस्क का. दिस इज पोस्टेरोलैटरल हर्निएशन ऑफ न्यूक्लियस पल्पोसस L4 और L5 के बीच में, L4 और L5 के बीच में. तो कौन सी रूट वैल्यू जाएगी? A slip disc at the following level, involvement of which root value? ये रहा, ये slip disc ये रहा. अब आप बोलोगे पोस्टरोलैटरल ही क्यों हुआ, मिडलाइन क्यों नहीं हुआ? क्योंकि पोस्टरोलैटरल herniation of nucleus pulposus is more common than midline. नॉर्मली जो आपको मिलते हैं वो यूनिलैटरल मिलेगा, एक तरफ का इन्वॉल्वमेंट होगा. जो ज़्यादा कॉमन है उसको पहले बात करो. ओके, सो इट इज पोस्टरोलैटरल herniation of nucleus pulposus L4-5. तो नर्व कौन सी जाएगी? इसके लिए जो मैंने आपको ट्रिक बताया हुआ है उस ट्रिक को देखो. होता क्या है कि सर्वाइकल रीजन में अगर सर्वाइकल स्लिप डिस्क का तो अलग कहानी है, सर्वाइकल स्लिप डिस्क का अलग कहानी है, ये लंबोसेकल है इसमें अलग कहानी है. लेकिन यू हैव टू अंडरस्टैंड दैट स्पाइनल कॉर्ड हैज terminated quite high at L1 lower border. At L1 lower border spinal cord has ended, but the nerves are coming down and they will have oblique course. The nerves are coming still down and they'll have oblique course. Now because they are having oblique course, there occurs one change. You look at this now. Say you are having this vertebra number L3 here. L3 vertebra, L4 vertebra. Between L3 and L4 vertebra, the nerve which is exiting is L3 nerve, but it is much more lateral. Between L3 and L4 vertebra, you have L3 nerve exiting, but it is much more lateral. That is not getting involved. Whenever you are having this herniation of nucleus pulposus. So when there is posterolateral herniation of nucleus pulposus, the nerve exiting between L3-4 is not involved. Then which nerve is involved? The next nerve is involved. And which is the next nerve? Plus 1. Plus 1. What is plus 1? L3 plus 1. L3 plus 1 means L4. Yes, L4 is involved. So that is what you have to remember, that whichever vertebra number is given, it's a trick basically. What is the trick? Trick is simple. Whichever vertebra is given, L3, L4 or L4, L5, whichever vertebra is given and there is some slip disc between them, say there is a slip disc here or slip disc here or maybe slip disc here between L5 S1. So there was a slip disc between L5 S1. Which nerve is involved? Upper vertebra plus 1. Upper vertebra plus 1, that is a trick. So upper vertebra plus 1 means what? Which nerve is involved? You can see for yourself. The nerve which is involved, upper vertebra is L3, so L4 nerve will be involved. Upper vertebra is L4, so L4 plus 1, L5. Upper vertebra is L5, so L6 nerve will be involved. But do you have L6 nerve? Do you have any nerve which is L6? So L6 means the next nerve, that is S1 nerve will be involved. So trick is very simple for lumbosacral slip disc. Whichever vertebra is given, go to the upper vertebra, add 1. L3 plus 1, L4. L4 plus 1, L5. L5 plus 1, L6. But there is no L6 nerve. It is the next nerve. It is S1 nerve. So S1, yes, like that you have to remember. So this is just some basic thing. Now you will say, what is the big fun in remembering all this? What is the purpose? It will be important when somebody will ask you cervical slip disc. Then what will you do? Same thing. In cervical slip disc, say C5, C6, there was a slip disc, or C6, C7, there was a slip disc. Then which nerve will be involved? Same trick, use the same trick. Which nerve is involved? C5 plus 1, which nerve? C5 plus 1, C6 nerve, yes, that will be involved. And what about this nerve between C6, 7? Upper vertebra plus 1. That means C6 plus 1, C7 nerve will be involved, yes. So when there is a cervical slip disc, C5, C6, upper vertebra plus 1, C6 nerve is involved, yes. And then C6, 7, upper vertebra C6 plus 1, C7 nerve is involved, yes. And what about if I have a slip disc here between C7 and T1? What if I have a slip disc at the C7, T1? Upper vertebra plus 1 nerve is involved. What do you mean C7 plus 1, C8 nerve is involved? Yes, C8 nerve is involved. Do we have C8 nerve? Yes, we have C8 nerve. Cervical vertebra are 7, but the nerves are 8, C8. So your trick is simple. Maybe it is cervical region or lumbosacral region. The trick is upper vertebra plus 1 nerve is involved. Use that. Which book for anatomy? You are preparing for your first year exam or final year exam? ये पोस्टीरियर थाई और नी वाला भी क्वेश्चन है, वो मैं अभी आप पहुंच रहा हूँ वहाँ पर। पोस्टीरियर थाई और नी वाला मैं पहुंच रहा हूँ। देखो, अगर किताब पूछते हो एनाटॉमी के लिए फर्स्ट ईयर में तो बीडी चौरसिया, और अगर लास्ट ईयर में मतलब एमबीबीएस अगर पीजी एंट्रेंस की तैयारी कर रहे हो तो मैं किताब लिखता हूँ, उस किताब का नाम है सेल्फ असेसमेंट एंड रिव्यू ऑफ एनाटॉमी। 600 पेज की किताब है, उसको पढ़ो, क्योंकि उसके अंदर आपको एम्ब्रियोलॉजी, हिस्टोलॉजी, न्यूरोएनाटॉमी, ग्रॉस एनाटॉमी, क्लिनिकल एनाटॉमी, रेडियोलॉजिकल एनाटॉमी, सारी एनाटॉमी मिलेगी 600-700 पेज में। पते की बात बता रहा हूँ, अगर फॉलो कर पाओ तो। फर्स्ट ईयर बीडी चौरसिया के अलावा कुछ मत पढ़ो, उसको भी पढ़ लो, बहुत बड़ी बात है। और अगर आप एमबीबीएस कर चुके हो और आप एंट्रेंस की तैयारी कर रहे हो तो सेल्फ असेसमेंट एंड रिव्यू ऑफ एनाटॉमी बाय डॉक्टर राजेश कौशल, जेपी पब्लिकेशन, जो भी लेटेस्ट एडिशन आती है उसी को पढ़ो, क्योंकि लेटेस्ट एडिशन इसलिए पढ़नी है क्योंकि जो नए क्वेश्चन आते हैं उनके आंसर्स भी उसके अंदर मिलेंगे आपको। अगर पत्ते की बात करनी और अगर फालतू की बात करनी है तो 10 किताबों के नाम गिना दूंगा और फिर वो उनमें फिर आप खोए रहोगे, तो मैं फालतू की बात मैं करता ही नहीं। पाकिस्तान में तो अब भाई, हाँ क्यों नहीं मिलेगी, बिल्कुल मिलेगी। पाकिस्तान में आपके जेपी पब्लिकेशन की किताबें ज़रूर जाती हैं। आप वहाँ अपने पाकिस्तान में आप जो आपके बुक सेलर्स हैं उनसे आप कहिए, या फिर आप amazon.com से निकाल लीजिए, मेरे ख्याल से शायद वो तो डिलीवर कर ही देंगे, मिल जाएगी, डेफिनेटली मिलेगी। चलिए आगे बढ़ते हैं। सो यहाँ पर आपने अपना आंसर क्या लगाया, क्योंकि यू हैव द लीजन एट L4-5, posterolateral herniation of nucleus pulposus, upper vertebra +1, L4 +1, L5 नर्व यहाँ पे इन्वॉल्व है, इसको आपने आंसर लगाना है, ये आपका आंसर है। ठीक है, आगे चलते हैं। नाउ दिस, just tell me whether this question was there or not. As intern, we should watch RR or main videos. See, if you are already in internship, then you don't have time to watch the main videos. It will be taking a lot of time. So RR, rapid revision. MBBS मैंने करी है गवर्नमेंट मेडिकल कॉलेज बैंगलोर से, 93 बैच। अमेजन नहीं चलता तो अब ये मुझे इन्फॉर्मेशन लेनी पड़ेगी, लेकिन जेपी पब्लिकेशन की किताबें आती होंगी पाकिस्तान में भी ज़रूर। अच्छा, नर्व क्लियर नहीं दिख रही थी, अच्छा नर्व तो यहाँ भी क्लियर कहाँ दिख रही है हमारे देश में कंप्यूटर बेस्ड टेस्ट आ गए, लेकिन कंप्यूटर की हालत जो है वो थर्ड क्लास खस्ता। ये जानते हो, ये मेरा जो टीवी है ये 4K टीवी है, मेरा कैमरा 4K है, तब भी आपको नहीं दिख रही होगी। तो वो जो एग्ज़ाम में बच्चे वहाँ बैठते हैं, मैं सोचता हूँ उनके साथ कितनी बदतमीजी होती है। हमारे एक जानकार दोस्त हैं, डॉक्टर आशीष हैं, वो खुद ही जाके एग्ज़ाम देते हैं, फिजियोलॉजी पढ़ाते हैं। वो कहते हैं मुझे ही कुछ समझ में नहीं आता, वहाँ पे बैठ के मेरे को नज़र नहीं आ रहा होता है, तो ये बच्चे क्या करते होंगे। और उनका एक्सपीरियंस, मेरी उम्र के हैं वो, 50 साल से ऊपर उम्र, मतलब मेरे से छोटे हैं वैसे। अगर एक फैकल्टी को ही नज़र नहीं आ रहा उस कंप्यूटर में, तो स्टूडेंट के साथ क्या होता है। मतलब दैट इज़ व्हाट, ये हिंदुस्तान है, यहाँ पे ऐसे ही होगा। यहाँ पे नर्व आपको नहीं नजर आएगी, आपको अपनी दिव्य चक्षुओं से देखना पड़ेगा, एक सिक्स्थ सेंस का इस्तेमाल कर ये आपको ऐसे तैयार कर देंगे कि पेशेंट सामने से आ रहा है, उसको आपको ब्लड टेस्ट करने की ज़रूरत नहीं है, सीटी स्कैन करने की ज़रूरत नहीं है, एक्सरे लेने की ज़रूरत नहीं है। आपके पास इतनी काबिलियत है कि आप उसको ऐसे स्कैन करके इसको ये वाली बीमारी है, वैसी वाली कैपेबिलिटी आपके अंदर ले आएंगे। वो ऐसे हैं हमारे यहाँ पे हिंदुस्तानी जो टीचर हैं और डॉक्टर हैं और एग्जामिनर हैं, आपको समझना चाहिए ये चीज़। सो व्हाट यू अंडरस्टैंड हियर इज, दिस इज द मसल विच इज टेकिंग ओरिजिन फ्रॉम रेव नंबर 3-4-5, और ये जो 3-4-5 से मसल जाती है और कोराकॉइड प्रोसेस की तरफ जाती है, दिस इज द पेक्टोरलिस माइनर, dissected specimen pectoralis minor, and piercing pectoralis minor, there is a nerve shown, and that nerve was then entering the pectoralis major. So this nerve which was shown puncturing the pectoralis minor, entering the pectoralis major, which has been removed here, and they were asking that which nerve is that. Now remember M, medial pectoral nerve, it has two limbs. It has two limbs. It supplies both the pectorals. It will supply not only the pectoral major, but it will also supply pectoral minor. This is how I remembered in my MBBS first year. In my first year MBBS I used to get confused. So what I thought was, medial pectoral nerve, M has two limbs, it will supply two muscles, pectoralis major as well as pectoralis minor. But if you are talking about the lateral pectoral nerve, the lateral pectoral nerve is having only one limb, so it will supply only one muscle. So which one will it supply? Lateral pectoral nerve has only one limb, it will supply only one muscle. So which pectoral? The one which will be large will have two nerves, making it hybrid. The muscle which will be large will require two nerves, making it hybrid. Are you trying to say lateral pectoral nerve supply only pectoralis major muscle? Yes, that is the point. And making it hybrid? Yes. What is hybrid? Hybrid is a muscle which will have more than one nerve supply. Hybrid is a muscle which will have more than one nerve supply, and questions keep coming on that also. Now somebody will say, पिछले 5 साल में तो आया नहीं ये क्वेश्चन, इसलिए तो मैं कहता हूँ पिछले 5 साल की तैयारी से नहीं होगा, पिछले 15 साल की तैयारी से होगा। 15 साल पहले जाओगे, मैं तो इतना बूढ़ा हूँ कि मैं तो पिछले 20 साल से पढ़ा रहा हूँ, मुझे पता है आया है। आपको लगेगा ये तो कभी पूछा ही नहीं। हाइब्रिड के ऊपर कितनी बार क्वेश्चन पूछे हैं और कंपोजिट मसल के ऊपर कितने क्वेश्चन पूछे हैं। हमसे पूछो जो हम तड़पे हैं, तरसे हैं आंसर ढूंढने के लिए, सालों साल हम लगा देते थे, हमको आंसर नहीं मिलते थे, तो हम तो वहाँ से निकल कर आए हुए हैं। तो इसलिए जो लोग पुराने होते हैं ना, कहते हैं ओल्ड इज गोल्ड। अब आजकल के नए लोग आगे हैं, ये कर लो, शॉर्टकट, अल्ट्रा शॉर्ट करके तुम क्या डॉक्टर बनोगे? डॉक्टर बनने के लिए देयर इज नो शॉर्टकट, आपको लंबे रास्ते से जाना ही होता है। शॉर्टकट इसलिए ले सकते हो कि आप रिवाइज कर रहे हो, ठीक है। तो यहाँ ज़्यादा समय नहीं लगाऊंगा मैं, लेकिन बात को समझने की कोशिश करो। सो मीडियल पेक्टोरल नर्व के पास दो लिम्ब हैं, तो दो मसल सप्लाई कर रही थी। मीडियल पेक्टोरल जो है वो पेक्टोरस मेजर और माइनर दोनों को सप्लाई करती थी। लैटरल पेक्टोरल नर्व एल के पास एक ही लिम्ब है, एक ही मसल सप्लाई करेगी। ऑब्वियसली जो मसल बड़ी होगी उसको ज़्यादा नर्व चाहिए होंगी, तो इसलिए लैटरल पेक्टोरल नर्व जो है वो पेक्टोरस मेजर को ही सप्लाई करती है, पेक्टोरल माइनर को नहीं सप्लाई करती। और क्योंकि पेक्टोरल मेजर को दो नर्व मिल गई, अब एक लैटरल पेक्टोरल नर्व मिल गई, एक मिडिल पेक्टोरल नर्व मिल गई, तो वो हाइब्रिड मसल हो गई। अब यही क्वेश्चन नेक्स्ट एग्जाम में आ सकता है। दिस इज हाउ वी टीच। व्हाट द वे वी टीच इज वी अंडरस्टैंड, वी ट्राई टू think and look into future, that what the examiner will be asking next time. That is how we teach, and that is how you should actually learn. If you are talking about competitive exams, I teach for those competitive exams only. So my mindset, my psychology, these are all strategic exams, and it is like a game of chess, I told you. And if you want to be good at the game of chess, you should be 2 steps, actually 4 steps ahead of your opponent, and your opponent is your examiner. So as you see, identify the arrow mark nerve, and that was a nerve which is supplying both the muscle. So if it is supplying both the muscle, it must be medial pectoral nerve. Okay. MD anatomy, which college? All India Institute of Medical Sciences, New Delhi, एम्स दिल्ली। हमारे ज़माने में एक ही एम्स होता था, 2001 की बात कर रहा हूँ। अब 25 एम्स हैं, सारे देश में एम्स हैं। मोदी सरकार की जय हो। Yes, your opponent is your examiner. Your examiner is your opponent. Yes. BTR, अभी तो मैंने कहा शॉर्टकट, अल्ट्रा शॉर्टकट। भाई डॉक्टर बनने जा रहे हो, क्या कर रहे हो? BTR is good, but if your basement is good, आपकी जो मेन वीडियोस देखे हुए हैं तब BTR हेल्प करेगा, अगर मेन वीडियो नहीं देखे हुए तो BTR कैसे हेल्प करेगा। डॉक्टर जैनब बहुत अच्छा काम कर रही हैं, लेकिन उनका जो अच्छा काम है वो सबके लिए एक जैसा नहीं है। जो पढ़ के आएगा उसके लिए काम करेगा, जो सीधा ही कि हम BTR से ही हमें रैंक मिल जाएगा वो नहीं। तो मैडम को आप फिर गलत नहीं बोल सकते, क्योंकि वो ये सोचकर चल रही हैं कि आपने पहले पढ़ाई की है तब आप उनके पास जा रहे हो। तो मैं कहूँ कि BTR गलत है तो ऐसा ये ठीक बात नहीं है। BTR इज गुड। क्यों गुड है? अब कोई पूछे भी क्यों, इसमें क्या अच्छा है? अच्छा ये है, पूरे 5-5.5 साल आपने पढ़ाई करी, पिछले 5-5.5 महीने आपने तैयारी करी, एग्जाम कल है या आप अगले हफ्ते है, तो 5.5 साल की पढ़ाई आप एक हफ्ते में कैसे करोगे? रिवाइज करना पड़ेगा। बुरी तरह रटो। BTR क्या है? बुरी तरह रटो। लेकिन बुरी तरह रटो का मतलब ये नहीं है कि 5 साल हमने कुछ नहीं किया, हम आ गए, मैडम अभी हमें 2 दिन में करा दो क्या MBBS, तो फिर तो गलती किसकी है? मैडम की है, आपकी है? BTR इज गुड बट ओनली फॉर दोज पीपल हु हैव वर्कड क्वाइट वेल। अगर 5.5 साल काम नहीं किया तो 5.5 महीने तो पढ़ के आओ कम से कम। नहीं, ऐसा मत कहो। देयर इज ऑलवेज होप, देयर इज ऑलवेज होप, देयर इज ऑलवेज होप। ऐसा मत कहो कि देयर इज नो होप। मोदी सरकार की जय हो। इतने सारे एम्स बन गए भाई, जम्मू कश्मीर में भी एम्स बन गया, बताओ। हिमाचल प्रदेश में जहां मैं पैदा हुआ वहां पे एम्स बन गया, बिलासपुर में। सोचा भी नहीं था मैंने कभी। Okay, so tell me, was this the question? Okay, trachea पे था pointer. Okay, so was it trachea or bronchi? Because here we have the bronchi, the right principal bronchus and left principal bronchus. Carina is also evident, little bit of carina is evident. But anyway, let me show you the similar diagram, and it is here. What you have to understand are some few basic things. The patient is in supine posture, feet towards us, head away from us. CT scans are taken, transverse CT scans are taken and viewed by convention inferior to superior. If it is inferior to superior, this is right side, this is left side, right, left. So this is the dark area, right lung, and that dark area is left lung. Now once you know this is right lung and that is left lung, you have to understand that posteriorly will have the vertebra. This is vertebra, body of vertebra, vertebral canal, the spine and the transverse process, vertebra posterior, and then anteriorly sternum. These are the ribs. Some sections of rib have come. So you are in the thorax. First of all, you should know it is in the thorax. So in the thorax you have taken a CT scan which is transverse section. Now look at these 3 vessels. Look at these 3 vessels. These 3 vessels you must remember the relation. The most to the right is superior vena cava entering the right atrium. To the right is the superior vena cava entering the right atrium, and then in the middle is ascending aorta. Ascending aorta. In the middle is ascending aorta. And what is to the left side? Pulmonary trunk. Actually it is pulmonary trunk goes this way, ascending aorta goes this way. Right ventricle, pulmonary trunk, left ventricle, ascending aorta. So look at the relation. Right ventricle, the pulmonary trunk, left ventricle, ascending aorta. Pulmonary trunk is anterior and going to left. Ascending aorta is posterior and going to right. So look at the relation. Remember, superior vena cava is right, sandwich in between is ascending aorta, and to the left side is the pulmonary trunk. Once you know that, look at this. Look at this. You will see that this is the superior vena cava to the right side, to the right side, and after that you will find that this is the ascending aorta, the ascending aorta, which is in the middle, and then you will see that this is the main pulmonary trunk bifurcation, and that is here, this one. This is, so remember the three vessel relation. Superior vena cava, the aorta is sandwich and then pulmonary trunk, and this diagram again and again they are asking. So bifurcation of pulmonary trunk. Now if that is ascending aorta, where is descending aorta? Descending aorta is more posterior and it is here. This is descending aorta. And what will be here? The arch of aorta. What will be here will be arch of aorta. So that is ascending aorta. This is descending aorta. How do you know this is descending aorta? Because it is related with the body of the vertebra slightly to the left side. It is related with the body of the vertebra, thoracic vertebra, and slightly to the left side. Aorta is to the left side embryologically, SVC, IVC are to the right side embryologically. Aorta is to the left side embryologically and SVC, IVC are to the right side of midline embryologically. So if it is to the left side, it is descending aorta. Now if this is descending aorta, what is in front of the vertebral body? What is in front of vertebral body is the esophagus. That will be esophagus. This will be esophagus. Esophagus is lying on the body of thoracic vertebra. And what is in front of esophagus? The trachea or bifurcation into bronchus. So trachea or bifurcation into bronchus, which you can see yourself here. This is carina, the carina, and this is right side. So right principal bronchus and that is left side. So left principal bronchus, bronchi. I'm not going into much detail, but this is some basic which we should have with us, and if we have this basic with us, then we will be able to answer. Maybe as you are telling, options were different, but still we could reach our answer. B was trachea. Okay, yeah, okay, fine. Maybe they have marked trachea. आर्च ऑफ एओर्टा दिख रहा था. अच्छा, आर्च ऑफ एओर्टा हो सकता है कि असेंडिंग और डिसेंडिंग एओर्टा की जगह आर्च ऑफ एओर्टा के लेवल पर सेक्शन लिया गया हो, मतलब सीटी स्कैन लिया है ना, तो आर्च ऑफ एओर्टा के लेवल पे लिया गया हो, तो तब आपको असेंडिंग डिसेंडिंग नहीं दिखेगा, फिर एक आर्च ही दिखेगी. पूरा पूरा यहाँ से लेकर यहाँ तक आपको एक आर्च दिखेगी. क्वाइट पॉसिबल. Which college do you teach students now? There is only one college, PrepLadder Private Limited. समय ही नहीं मिलता कुछ और करने के लिए. सिर्फ PrepLadder के लिए वीडियो बनाओ. सर आपने वीडियो नहीं भेजी, इंग्लिश में बनाओ. सर अब इसको काले स्क्रीन में बना दो, इसको पीली स्क्रीन में बना दो. सर आपने ऐसे कपड़े क्यों पहने, आप काले कपड़े पहन के बना दो. सर आपने ये टॉप ये पीछे ये क्यों रखी है, इसको काट दो, गंजे होके बना दो. ये PrepLadder वाले ऐसे ही करते रहते हैं, तो टाइम ही नहीं बचा किसी और कॉलेज में पढ़ाने के लिए. मजाक कर रहा हूँ, लेकिन मेरा सारा 95% ऑफ माई टाइम इज़ इनटू PrepLadder. और जो 5% बचा उसमें मैं पानी पी लेता हूँ, सो जाता हूँ, खा लेता हूँ, परिवार से बात कर लेता हूँ. 5% लाइफ है, 95% एनाटमी है. Okay, so if this is the diagram, again you can do the same thing. You can tell this is the body of thoracic vertebra, these are the ribs basically, this is the sternum, the ribs, multiple sections, scapula on the side, and this is the vertebral canal in which you will have the spinal cord. This is the spine of the vertebra. Now once you know the vertebra and the bony cage, now same thing, you can tell this is superior vena cava, that is the ascending aorta, and this is the pulmonary trunk bifurcation. And if that is the ascending aorta, this is descending aorta, and if this is a descending aorta, just in front of the, let us take some other color, just which color should we take? Okay, maybe here. So you will have the esophagus, and in front of the esophagus you will have what is called as the, let us take this color, the bronchi, the right principal bronchus and the left principal bronchus. Not going into much detail, but I have written A is ascending aorta, B is superior vena cava, C is pulmonary trunk, and D is the descending aorta. Maybe you were having marker on the esophagus, maybe you are having marker on trachea also. You can understand body of vertebra and then esophagus, then trachea, and then the vessels of the heart. सैलरी कितना है प्रेप लैडर से? सैलरी कितना है क्या बताऊं, ये तो बिजनेस की बातें हो गई। ठीक है, चल जाता है, काम चल जाता है। अब यहाँ कुछ बोलूँगा तो बाकी के जो टीचर हैं वो नाराज़ हो जाएंगे, अच्छा इसको इतना मिलता है, हमको तो मिलता नहीं है। ठीक है, काम चल जाता है। Arcus senilis in Horner syndrome, Arcus senilis in Horner syndrome, Horner syndrome Arcus senilis क्यों होगा? अगर नियोनेटल Horner syndrome होगा तो Arcus senilis थोड़ा नहीं होना चाहिए उसके अंदर। Arcus senilis तो ओल्ड एज में आता है मेरे ख्याल से, उसकी बात कर रहे हो? अच्छा, एनाटॉमी में ऑनर्स मिला था, वेरी गुड प्रेम। देखो फर्स्ट ईयर की एनाटॉमी और ये एनाटॉमी अलग है, ये एनाटॉमी नहीं है, ये एनाटॉमी है। ये एनाटॉमी प्लस रेडियोलॉजी, एनाटॉमी प्लस ऑर्थोपेडिक्स, एनाटॉमी प्लस ईएनटी, एनाटॉमी प्लस एनेस्थीसिया। ये इंटरडिसिप्लिनरी क्वेश्चंस आते हैं। अब प्लेन एनाटॉमी आपसे ये थोड़ी पूछते हैं कि एक्सिलरी आर्टरी की ब्रांचेस बताओ एक्सिला में कितनी है, फर्स्ट पार्ट से कौन आ रही है, सेकंड से कौन है। अब ऐसे क्वेश्चन नहीं आते। अब आते हैं कि ब्लॉक हो गया है, यहाँ पर सर्वाइकल रिब थी, ब्लॉक हो गया है, स्कैपुलर एनास्टोमोसिस में कौन सी वाली आर्टरी से ब्लड जाएगा, ऐसी वाली एनाटॉमी है। तो वो एनाटॉमी अलग है, उसमें ऑनर्स मिला था, बहुत अच्छी बात है। अब उस ऑनर्स को अब थोड़ा सा, और ये स्ट्रेटेजिक एग्जाम होते हैं, थोड़ा सा अलग होते हैं, ये क्लिनिकल ओरिएंटेड एग्जाम होते हैं। आपकी अभी आप देखो जितने भी अभी क्या है, असल में जब 2001 की बात कर रहा हूँ, जब हमने अपना ऑल इंडिया पीजी दिया था, जब एम्स ऑल इंडिया पीजी कंडक्ट करता था। अब ये एनबीई वालों ने तो बड़ा गर्क कर ही रखा है, कोई सुनेगा कोई तो मुझसे नाराज हो जाएगा कि मेरे बारे में गलत क्यों बोल रहे हैं, लेकिन एनबीई वालों ने बेड़ा गर्क कर रखा है। जब एम्स ऑल इंडिया पीजी कनेक्ट करता था तब वो स्टैंडर्ड ही कुछ और था। उस वक्त सारे क्वेश्चन ऐसे आते थे जो अब आने लगे हैं। एनबीई वालों को आते 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 अकल आ गई कि ये बच्चे जो हैं ये डॉक्टर हैं, इनको डॉक्टरों वाले सवाल पूछे जाए, ये आगे जाके पेशेंट देखने वाले हैं, तो ऐसे सवाल होने चाहिए। तो अब जाके अकल आई है इनको। Okay, tell me about this question. Yes, रट्टाफिकेशन से डॉक्टर कोई कैसे बन सकता है? कोई कैसे रट्टाफिकेशन से डॉक्टर बन सकता है? डॉक्टर बनने के लिए भाई तो आपको दिमाग को शार्प करना पड़ेगा। पेशेंट आएगा सामने तो कैसे होगा? आपका दिमाग शार्प बहुत ज़रूरी है, खासकर इमरजेंसी में बैठे हो, वहाँ से स्नेक बाइट आ गया, आपको यही नहीं पता कि ये कोबरा बाइट है या वाइपर का बाइट है, उसको हेमरेज से ब्लीडिंग होकर मर जाएगा या कि नर्वस सिस्टम डिप्रेशन में चला गया है, एकदम से डिसाइड करना होता है। और 6 पेशेंट आ रखे हैं, 6 को सांप ने काट रखा है, किसी को कोबरा ने, किसी को वाइपर ने। एएसबी लगा तो रहे हो एंटी स्नेक वेनम, पर किसको क्या लगा रहे हो? दिमाग एकदम से शार्प होना चाहिए। आपसे ज़्यादा शार्प तो नर्स का दिमाग होता है। कहती है सर ये क्या कर रहे हो, ये कोबरा बाइट थोड़ी नहीं है, इसको आप ये एएसबी कौन सी वाली लगा रहे हो? नर्स का दिमाग ज़्यादा तेज हो जाता है डॉक्टर से। तो आपको रट्टाफिकेशन से कुछ नहीं होगा, आप एग्जाम पास कर लोगे, डॉक्टर अच्छे डॉक्टर नहीं बन पाओगे, पेशेंट मर जाएगा, आपकी गोद में मर जाएगा। हाउ पेनफुल इट विल बी इफ द पेशेंट डाइज इन योर आर्म्स। ऐसा नहीं होने देना आपने। द नर्व पासिंग through the arrow marked region has been lesion. What is the clinical presentation? Now you have to tell me, where was the arrow? Was it in the superior orbital fissure? Was it in the superior orbital fissure? and if it was in the superior orbital fissure, then fine. Then we know there are 3 motor nerves and 3 sensory nerves passing, 3 motor, 3 sensory. The motor nerves are the one which will go and supply the eyeball in the orbit, and motor nerves, you know the formula, LR6SO4 remainder 3, now number 3, 4 and 6 will be passing. But which 3 sensory nerves will be passing? The sensory nerves which are passing are branches of ophthalmic, trigeminal. Ophthalmic, trigeminal. So what are the 3 branches of ophthalmic trigeminal which are passing? Let us look at a diagram, but first you tell me that was this the question? Yes, you work for 24 hours, nurse works for only 6 hours. Very true. तो उसका दिमाग तो शार्प होगा ना, सो के आई है वो, आपको तो सोना भी नहीं मिला। ब्रश, मेरे को याद है बोरिंग हॉस्पिटल में ब्रश करने का टाइम नहीं होता था, नाइट ड्यूटी खत्म नहीं हुई ओपीडी शुरू हो जाती थी, भाग के जाके एक इडली खा के आते थे, कॉफ़ी पी के आते थे क्योंकि नींद ना आ जाए ओपीडी में बैठकर। हमारी तो हिंदुस्तान में खासकर गवर्नमेंट सेक्टर में तो डॉक्टर की, लेकिन तभी आप अच्छे डॉक्टर बनोगे, ये भी ध्यान में रखो, तभी बनोगे। Okay, so tell me, if this was the question, then you have to understand we are talking about some details. I'm not going to much details anyway, but you have to remove the skull cap, remove the brain, look into floor of cranial cavity, anterior middle posterior cranial fossa, magnify this region where you are talking about the superior orbital fissure. So as you magnify, it is on the right side, right side, right side, right side, superior orbital fissure. As I am telling, there are 6 nerves passing. So if you say 6 nerves, there are 6 nerves passing in superior orbital fissure, 3 motor and 3 sensory. The motor nerves are now number 3, 4, 6 because they have to supply the eyeball muscles, and 5, 1, 3 branches. What are the 3 branches of ophthalmic trigeminal? Frontal, lacrimal, nasociliary. Frontal to supply forehead, lacrimal to supply lacrimal area, and nasociliary to supply the nose. So the names are LFN. What is LFN? Lacrimal is lateral. Lacrimal is lateral, L for L. Lacrimal is lateral, lacrimal, and then frontal, and then medial, nose is medial. So lacrimal, frontal, and the nasociliary, yes. Lacrimal, frontal for the forehead, and then you have the nasociliary nerve to supply the nose. A question came, herpes involving ophthalmic trigeminal, where are the pustules? Herpes zoster involving the ophthalmic trigeminal, where are the pustules? Tip of the nose, ophthalmic trigeminal. You see here. So ophthalmic trigeminal, if you trace, tip of the nose, bridge of the nose, upper eyelid, scalp and forehead. This is ophthalmic trigeminal. Ophthalmic trigeminal, upper eyelid, tip of the nose and forehead. So if you are telling tip of the nose, bridge of the nose, upper eyelid and forehead, that is the ophthalmic trigeminal. Maxillary, the maxilla region, cheek and lower eyelid, upper lip. Maxillary division of trigeminal, maxilla bone, skin over maxilla, because both are sensory, they are only sensory, pure sensory, only sensation. So maxillary division trigeminal, maxilla, chin, the cheek, and then lower eyelid and upper lip. So you are telling now that if we are talking about the maxillary division, upper lip and lower eyelid, yes, and lateral nose, yes, lateral nose, not the tip, lateral nose. So lower eyelid, upper lip, yes, and lateral nose, yes. What is that? Maxilla bone, maxillary nerve. And what about the mandibular? Mandibular, you can see for yourself, the skin over the mandible, lower lip, but except the angle of the mandible. So you are talking about mandibular nerve now, skin over mandible, lower lip, but except the angle of the mandible. Why? Because that is supplied by greater auricular nerve, the one which supplies greater part of auricle. So this is supplied by greater auricular nerve which is supplying greater part of auricle. Yes, this is a different nerve, it will supply the greater part of auricle. Now remember, a question came on auricle also. Most of the auricle laterally and most of the auricle medially is supplied by same nerve which is greater auricular nerve. We will talk about that later, but here this is about trigeminal. Okay, so which nerve are you showing here? As you see, we have magnified right sided superior orbital fissure, magnified here. This is the number 3. Let me change the color, maybe this color. This is the number 3. This is the number 6. This is the number 4. So as you enumerate, the number 3, this is the number 6, this is the number 4, the number 3, 4, 6, 3 motor nerves going to fissure. And then you can see this is trigeminal ophthalmic division, which will give 3 branches here, LFN, lacrimal frontal neociliary, lacrimal frontal neociliary. So these are the 6 nerves which pass superior orbital fissure. So what will be the sensory loss then? If there is a lesion in the superior orbital fissure, sensory loss will be in the lacrimal area, frontal area and neociliary area. That was your question. भाई देखो, अगर आप तैयारी की बात कर रहे हो, if you are preparing for your entrance exam, the very first thing is you have to practice as many MCQs as possible. These days you have mock test, grand test. Start giving mock test and grand test. You will understand that what kind of questions appear in the recent pattern. That is the beginning and that is the end also. Now once you know the orientation, which type of questions are appearing, you have to select some topics, because there are very few topics they are asking, very few topics, again and again and again, same topics. They ask you only 25% of the, say in anatomy there are 100 pages which you have to read throughout MBBS. Throughout MBBS you have to read 100 pages of anatomy, say for reference. Only 25 pages are important, they do not ask 75. You have to understand this. Let us assume there are 100 pages of anatomy which you should need throughout MBBS. Only 25 pages are important, but which 25 pages? How will you know that? By practicing more and more MCQs, you will know they ask neural crest cell, they ask superior orbital fissure, they ask this foramen rotundum. Just focus upon that. Don't focus upon other things and read it again and again and again. Maybe you can watch some of these videos which are available in YouTube, or maybe you can take some app like PrepLadder app, if possible main videos. But if you do not have time for main videos, like one of you were telling it is internship, how can I do main videos? Main videos you teach anatomy for 80 hours, 80 hours, I do not have 80 hours to study anatomy, then how will I finish off medicine which is 300 hours? So not possible, then do the rapid revision at least and keep practicing MCQs. Sincere advice. Okay, so if this is your question, then superior orbital fissure, so loss of sensation, nasopharynx, maxillary area, jaw area, scalp and nose. This is your answer. That should be your answer. There might be some changes. Superfecundation, that was a question in what is that, forensic I believe. You want to take dermatology, very good. सर मैं तो डर्मेटोलॉजी लेना चाहता हूँ, मुझे ये सुपीरियर ऑर्बिटल फिशर क्यों पढ़ा रहे हो, ये आपका सवाल हो सकता है। लेकिन डर्मेटोलॉजी में जब ये हर्पिस जोस्टर आएगा यहाँ का, तो क्या बोलोगे, या टोलोसा हंट सिंड्रोम आ जाएगा, टोलोसा हंट सिंड्रोम का पेशेंट आ जाएगा आपको, टोलोसा हंट सिंड्रोम का पेशेंट आ गया, बोलेंगे ये तो अफ्था का केस है, अफ्था में भेजो, ये हर्पीज का केस्टर तो आपके पास आएगा ना, तो आपको याद होना चाहिए कि कौन सी नर्व है यहाँ, ऑफ्थेल्मिक है या मैक्सिलरी है. Understood that after some time you will be specialized and super specialized in one particular branch, and maybe you don't even want to know what is the arterial supply to uterus. I am a dermatologist, why should I know arterial supply to uterus or what is prolapse of uterus? Understood. But the thing is, you have to go through the basics, you have to go through the basics, and it is debatable whether you should read it or read it in so much of detail, but Indian system is very, इसको कहते हैं पुख्ता है, आपको कमज़ोर नहीं छोड़ते ये, बाद में इस्तेमाल आए ना आए. अब ऐसे तो आप पूछोगे, आपका सवाल हो सकता है, मैं तो डॉक्टर हूँ, तो मेरे को ट्रिग्नोमेट्री में वो साइन थीटा कॉस थीटा टैन थीटा क्या पढ़ाया था, क्या उसका क्या फ़ायदा हुआ मुझे, इससे क्या फ़र्क पड़ रहा है कि बारिश जो है 30 डिग्री के एंगल पे आ रही है, 45 डिग्री के एंगल पे आ रही है, रिलेटिव वेलोसिटी में साइकिल चला रहा हूँ, तो मैं बारिश में गीला होऊंगा या नहीं होऊंगा, ये आपका सवाल हो सकता है. तो आपने फिजिक्स ही क्यों पढ़ी, आपको तो डॉक्टर बनना था, फिजिक्स क्यों पढ़ी. लेकिन जब आप कहीं इमरजेंसी में हो और इलेक्ट्रोलाइट इम्बैलेंस होगा, कहीं ना कहीं पे आपकी मैथमेटिक्स भी काम आ रही है, फिजिक्स भी काम आ रही है, केमिस्ट्री भी काम आ रही है. ऐसा मत सोचो, ये सोच ही गलत है कि हम ये क्यों करें, आगे तो मेरे को इसका कोई इस्तेमाल ही नहीं है. आप जानते ही नहीं, हो सकता है कभी आ जाए, तब क्या करोगे. इसलिए ऐसा मत सोचो कि मुझे तो ये करना है तो मैं ये क्यों करूं. वो मेरी सोच है, हो सकता है मैं गलत भी हो सकता हूं. ओके, व्हाट अबाउट दिस, ये भी एक खतरनाक टॉपिक है. इट्स वेरी डेंजरस. टेल मी. No, whole nose is not supplied by nasociliary. Nasociliary is supplying ciliary eye. You touch the cornea, it will be activated. Nasociliary, ciliary touch the cornea reflex is carried by nasociliary. But nasociliary nerve also give ethmoidal nerves. And nose, deeper nose, ethmoidal nerves, they are from nasociliary. If you say external nasal, it is coming from outside. External nasal is from outside. It is from maxillary nerve. So maxillary nerve will give external nasal. But this nasociliary will be supplying inner and midline nose, like the tip of nose skin and mucosa inside is by nasociliary. So nasociliary nerve supplies, ciliary means the cornea, and nose also outside and inside. What is your question? Whole nose, not whole nose, because laterally it will be branches of maxillary trigeminal, not whole nose. Midline nose you can say is supplied by nasociliary. Okay, before I answer this question, you look at this, and I am telling you it is very dangerous topic. Anatomy, physiology, people keep fighting with each other. This is the answer, that is the answer. So I have read physiology books, lot of them, electrophysiological books, anatomy books, medicine books, derma books. Then, so what are we talking about? We are talking about Merkel cell, superficial to deep in the skin. Merkel cell is actually in the basal layer of the skin epidermis. So Merkel cell is in the basal layer of skin epidermis, and Merkel cell is for light touch sensation. Light touch sensation, like I am holding a pencil, this is light touch sensation, but it is slowly adapting. Because it is slowly adapting, it will take time to detect, slowly adapting. So Merkel cell in the basal layer of skin epidermis, slowly adapting. Holding pen, it will tell me I am holding the pen, but it will take time. Second thing, form and roughness of skin. You feel the skin of a kid, newborn kid, feel it and feel your skin. Your skin is rough. Newborn kid, it is smooth. We'll tell that. That smoothness and roughness. But you spend some time, it is slowly adapting. And then tactile discrimination, but 2-point discrimination. Static 2-point discrimination. Like 2-point discrimination, static, you are not moving, you are static. Static 2-point discrimination, that is done by Merkel cell. Everything is important, be careful. Then sustained pressure. Sustained pressure. My finger are under sustained pressure, but it is light, light. It is not deep, it is light. So light is important. If you say deep, then deep. Deep is something like Pacini and Ruffini. They are deep. They are deep. They will detect the deeper thing. It will detect only light thing. Okay, and learn Braille. What do you mean by learn Braille? Blind people learn Braille. C-A-T. Cat. You are learning Braille. Use this receptor because it has very narrow receptive field, very precise. It has narrow receptive field, and that is why it is very precise, very precise, very precise. Okay, now this is Merkel. What is the next one? Next one you will see is Meissner. Meissner is at the dermoepidermal junction, dermoepidermal junction, dermoepidermal junction, Meissner. Okay, what is Meissner doing? Meissner is light touch again, but be careful now. It is rapidly adapting, because Meissner is rapidly adapting, light touch only. This is also light touch, this is light touch. But what kind of light touch is this? Like the flutter of a butterfly, a butterfly wings. That flutter will be detected because it is rapidly adapting. And then slip on skin. You have a silk, rumal, hanky, handkerchief. That feel of that silk on your skin, it is rapid, slippery. It is rapid. Okay. Then texture. Is it silk or is it, cotton? But fast, rapid. Then tactile discrimination again, but this tactile discrimination is dynamic, because it is rapidly adapting. Be careful. If a question comes, tactile discrimination, what should I answer? You can answer Merkel cell if it is static, tactile discrimination, 2-point discrimination, which you do in the neuro ward. And this one is rapidly adapting. What is rapidly adapting? Reading Braille. Remember, if a question comes, which receptor help you reading Braille? Your answer is the Meissner, because you read Braille fast. Maybe the best receptor to read Braille is Merkel, but it will help you learn, not read Braille. The Merkel will help you learn Braille, but not read Braille. If you want to read Braille, you have to make sentences, sense of sentences, you have to go fast, and that can be done only by Meissner. So be careful about these things. These are very dangerous topics and you are definitely going to make mistakes, I know that. Okay, then what about this Pacinian? Pacinian is rapid vibration. Okay, slow vibration, that is Meissner. Meissner is slow vibration, like I told, flutter of the butterfly wing. So that flutter 50 hertz of frequency, then it is Meissner. But if it is 300 hertz rapid vibration, then it is Pacinian. Pacinian for rapid vibration, and Pacinian for pressure also, P for P, pressure. But remember, it is pressure and not sustained. That means it is also rapidly adapting. These two are rapidly adapting. You have to be very careful. These two are rapidly adapting, means the Meissner and the Pacinian. And this is also pressure, but it is not sustained. This was also pressure, Merkel was also pressure, but that was sustained. You may not have read all this in any book at all, because it is not given in a single book. It is accumulation of anatomy, physiology, electrophysiology, medicine, derma book, all. Why? Because questions have come frequently and we are making mistakes. If you want to minimize mistake, follow the table. And what about Ruffini? Ruffini is for skin massage. When you do the skin massage, it is slow adapting. First of all, it is slow adapting, and it is skin stretch, and that too sustained. Skin stretch and that too sustained skin stretch, like massage, sustained. And then tension in the deep skin and tension in the joint capsule, like for proprioception. So a lot of detail actually. Anyway, with all that information, can you answer the question? That is the point. Can you answer the question? The question was on foramen rotundum. If the question is on foramen rotundum, then maxillary nerve will be compromised, lower eyelid, upper lip, lateral nose, skin on maxilla will be compromised. If you are telling foramen rotundum was the question, Dr. Priya, if the question was on foramen rotundum, then through rotundum goes maxillary nerve. Maxillary nerve, if it is compromised, lower eyelid sensation, upper lip sensation, lateral nose sensation, and skin over maxilla sensation will be compromised. Okay? हाँ, स्पीड अप करिए, बिल्कुल ठीक है. तो बताओ इसका आंसर. ये रफीनी बताओ. रफीनी अभी हमने बोला रफीनी. We have talked about Ruffini. Ruffini is first of all slow adapting and very deep. It is slow adapting and very deep. Massage की बात करी थी. So Ruffini, you have to do it with stretching. Okay, that will be good. Now what about the Merkel? What about Merkel? Merkel vibration में तो है ही नहीं. Sustained pressure है. You can do that. Sustained pressure है. Pacinian. What about Pacinian? Pacinian was for rapid vibration and pressure also. But the pressure should be not sustained. And what about Meissner? If you are talking about the Meissner, then Meissner is of course fine touch, maybe, but I am not very sure. These were the options. If these were the options, this is the answer. Yes. Jake, so the point was arrested or completed after metaphase 2. देखो, अगर आप बात कर रहे हो secondary oocyte is arrested in metaphase 2 of meiosis 2. Secondary oocyte is arrested in metaphase 2 of meiosis 2 and then undergoes ovulation, undergoes fertilization. If not fertilized, undergoes menstruation. It is the same cell. Secondary oocyte arrested in metaphase 2 of meiosis 2 is the one which undergoes ovulation. Rarely may be fertilized. Mostly it is menstruated by the end of cycle. Rapid and low vibration. अगर रैपिड एंड लो वाइब्रेशन तो कोई इशू नहीं है. रैपिड वाइब्रेशन 300 हर्ट्ज हो गया पैसिनियन कार्पस्कल. 50 हर्ट्ज हुआ जो हमने फ्लटर की बात करी तो मीजनर हो गया. मीजनर लो वाइब्रेशन, पैसिनियन हाई वाइब्रेशन. 300 हर्ट्ज 50 हर्ट्ज. After ovulation it is arrested. Secondary oocyte arrested in metaphase 2 of meiosis 2 is ovulated. Jake, it is arrested, not completed. Okay, so we go fast. Yes, I understand. Okay, I think these questions they have come very frequently and you must be knowing the answers quite perfectly. What is the diagnosis on this image? You see, what you find here is this is umbilical cord which is normal. Here are the opening of ureters. This is the trigone that is open. So posterior wall of urinary bladder is open, ectopia vesicae, or you can call it as bladder exstrophy. Ectopia vesicae or bladder exstrophy, because you can see the trigone of urinary bladder outside, and you can see the scrotum. This is the scrotum, and you can see the penis is bifid, pelvic bone is bifid, pelvic bone is bifid, penis is bifid, scrotum is evident here, and urinary bladder is open. It is ectopia vesicae. In the similar fashion, they have asked you other things, so let me just take you through these details. As you will understand, this was ectopia vesicae, as we told that is the ureter opening, urethra opening, trigone, ectopia vesicae. What is this? Here you see inside the umbilical cord you are having liver and intestine, omphalocele. This is omphalocele. Inside the umbilical cord you are having liver and intestine. This is omphalocele. It is a midline problem. Most babies are dead babies. So it is a midline problem. Most babies are dead babies. They don't survive, most of them. And this is covered by amnion. It is covered by amnion. So here it will be covered by amnion. Deep to amnion you will have the peritoneum, and of course the jelly, Wharton's jelly, because you are inside the umbilical cord. You are inside the umbilical cord, the outermost layer will be amnion, then Wharton's jelly, then peritoneum. So what are the layers of omphalocele? What is the outside one? Amnion. What is inside? Jelly. What is still inside? Peritoneum covering the liver and intestine. That question came. That is omphalocele. And what about the gastroschisis? Gastroschisis, you will see that umbilical cord is normal. Umbilical cord is normal, but then there is some intestine which has come out on the right side of umbilicus. Gastroschisis. This is a case of gastroschisis. Umbilical cord is normal. On the right side of umbilicus, some intestinal herniation, no covering of amnion, no covering of amnion, exposed to amniotic fluid, burnt also, exposed to amniotic fluid and burnt also, burnt tissue, and this is gastroschisis. And then this is Meckel's diverticulum. This is the Meckel's diverticulum near the ileocecal junction, patent vitalointestinal duct, patent vitalointestinal duct, Meckel's diverticulum, and that 2% population, 2 inches, 2 feet from ileocecal valve and all that. And that is where a weeping umbilicus is there. Weeping umbilicus, urine coming out. Weeping umbilicus, urine coming out because persistent allantois, or you can say persistent urachus. Persistent allantois is better. Allantois, if it is obliterated, then it becomes urachus. But if allantois is persistent, then you will have what is called urachal fistula. This is urachal fistula from the apex of urinary bladder. From the apex of urinary bladder, some urine comes to umbilicus. That is the weeping umbilicus. Now, weeping umbilicus could be some blood coming out, fecal matter or urine. If it is urine coming out, urachal fistula. If it is fecal matter coming out, then it is fecal fistula. But what is fecal fistula then? That is when the Meckel's diverticulum brings fecal matter from terminal ileum, it is bringing the fecal matter from terminal ileum to the umbilicus. So from the terminal ileum, the Meckel's, it is not a diverticulum now, it is a fistula. Bringing fecal matter to umbilicus, that is fecal fistula, and it is basically a problem of vitalointestinal duct. Meckel's anomalies are problem of vitalointestinal duct. Urachal anomalies are basically allantois anomalies. So with that idea, lot many questions have come. So what do you think is the answer here? Fecal discharge from the umbilicus. If it is fecal discharge from the umbilicus, then obviously we are telling Meckel's diverticulum, vitellointestinal duct being patent, and ileal diverticulum, because it is fecal. If it was urachal, then it should be urine. So ileal diverticulum. Omphalocele gastroschisis, they don't give you some fecal matter at the umbilicus. Answer is ileal diverticulum. It is nothing. It is basically the vitellointestinal duct, and this diverticulum, I don't know what the option, because obviously we get these options from students, but it must be something attaching to ileum, terminal ileum, and it is a persistent vitellointestinal duct which can bring the fecal discharge to the umbilicus. Epithelium वो अभी आएगा. Okay, little fast, that is what I am trying to do. What about this? The covering of omphalocele. We already discussed covering of omphalocele and amnion. There is no chorion, don't think about all this. Amnion. The outermost is amnion. Then after that, what is there? It is the jelly, Wharton's jelly. And after Wharton's jelly, what is there? Wharton's jelly, the one which is in the umbilical cord, and deep to that will be the peritoneum. And what will be deep to peritoneum? Liver and intestine. Liver and intestine. These are the layers of omphalocele. Midline problem, structures inside umbilical cord covered by jelly, Wharton's jelly. Most of these are dead babies. What is this? What is the answer? What is the diagnosis based upon the image? I think there is overlap of things, but obviously again it is ileal diverticulum. Terminal ileum, Meckel's diverticulum basically, Meckel's diverticulum. The formula of 2 to 2, 2% population, 2 inches long, 2 feet from ileocecal valve, Bailey love. What are the effects of lesion in broadband area number 22? If it is broadband area number 22, let me just show you a diagram here. You know, whether we are talking about reading or sign language or listening, it is about language. And if you want to listen or read or even braille, that comprehension, understanding of language, comprehension is by area number 22, this area. So area number 22 is for comprehension of language. It is the superior temporal gyrus. It is the superior temporal gyrus posteriorly, and area number 22, that is Wernicke's sensory speech area. So superior temporal gyrus more posteriorly, area number 22, superior temporal gyrus more posteriorly, area number 22, Wernicke's sensory speech area, it is for listening, reading, sign language or braille reading, whatever, comprehension of language. If that is working, from there arcuate fascicle, from there goes the arcuate fascicle, it is carrying the 22 to 44, it will carry information to 44, not only 44 but 45 also. That is Broca's motor speech area, and Broca's motor speech area is for planning of the movement of speech muscles. It does not move the muscle, it will plan. So it is to plan the movement of speech muscles. This is language, and that is mostly on left cerebrum, mostly on dominant cerebrum, left cerebrum. Now what happens? If I have a lesion in the Broca's area, if there is a lesion in the Broca's area, comprehension is gone. This patient cannot understand language, and still he will try to communicate, and he cannot communicate, so he will be very talkative. So these patients, they have non-stop nonsense speech, non-stop nonsense speech. These patients, Wernicke's sensory aphasia, receptive aphasia. So as you can see here, the Wernicke's receptive aphasia, speech is fluent, but it is nonsense. It is, comprehension is impaired. Speech fluency is good. So Wernicke's is wordy but makes no sense. Superior temporal gyrus. So this was Wernicke's. What will happen if I have a lesion in the Broca's? Then you cannot plan the speech muscles. So hesitancy in speech, they don't talk much. So as you talk about the patient who is having Broca's or expressive, their expression is gone, they don't talk much. So their expressive aphasia, non-fluent, because they are unable to articulate the speech muscles properly. Comprehension is intact, they can understand what you are talking about, but the speech is compromised. So fluency is compromised. Now what is conduction aphasia? In conduction aphasia, which is a problem of this arcuate fascicle, the comprehension is good, fluency is good. Comprehension is good, fluency is good, but poor naming and poor repetition of language. That is called conduction aphasia. So as you see here, you will notice conduction aphasia, fluency is good, comprehension is good, but there is poor naming and poor repetition. Arcuate fascicle, if it is compromised, poor naming and poor repetition of the language. And global means everything is gone. Global means everything gone. So what about the answer then? This question is asking area number 22. And if you say area number 22, that is Brodmann area number 22, that is Wernicke's sensory speech area, that is the one which is helping us in comprehension of language, then the receptive aphasia, there is a problem with reception. Now what about expressive? If it was expressive, then you will say Broca's motor speech area is compromised. What about poor repetition? Conduction aphasia, arcuate fascicle is involved. And what about poor naming? Same thing. This can be seen in conduction aphasia with intact comprehension, intact fluency. But be careful, poor repetition of language and poor naming can be found in other aphasia also. So that is why the table was given to differentiate between different type of aphasia. But here answer should be receptive, because he is unable to understand the language. क्लास कितने बजे चलेगी? जब तक कि ख़त्म नहीं हो जाता तब तक तो चलेगी। ये बताओ, ये आप मेरे ख्याल से ये सवाल पूछा था आपने। डॉक्टर नजीब के मुकाम तक पहुंचना तो बहुत मुश्किल है। डॉक्टर नजीब का स्तर बहुत अल्टीमेट है, हम तो कोशिश करते हैं बस वहाँ नहीं पहुँच सकते। और मैं तो सिर्फ एनाटॉमी पढ़ाता हूँ, और एनाटॉमी, फिजियोलॉजी, मेडिसिन, आप बोलो कुछ भी सब पढ़ा देंगे वो, उनका अलग लेवल है। ओके, सो पेशेंट प्रेजेंटिंग विद पेन इन द बैक ऑफ द थाई एंड लेग। अब यहाँ पर एक गड़बड़ है। If you ask an anatomist, I'll say it is S2. This is my answer. But if you ask an orthopedician, he'll say no, that is not the answer. There may be difference of opinion, but I think this is the answer. But why this is the answer? Because you're telling pain is in the back of thigh and leg. So what about that? You should know the dermatomes. What dermatome? Is the pain because of skin, or is the pain because of some other reason? I think it is a pain of skin. Even if you talk about sciatica, even if you talk about sciatica, it is S2. How come it is S2? Why answer is S2? Look at this, Harrison medicine. This is Harrison medicine. That is why I tell you, Harrison medicine is a very good book and you should follow it. Okay, what is Harrison telling? This is front view, posterior view. Look at the calf region, look at the posterior thigh, it is S2. That is S2 dermatome. That is why I am giving my answer as S2. Posterior thigh and posterior leg, that is calf, that is all S2. So if you have pain in this region, I believe it is S2 root value which is involved. Now orthopedician will say no, it is not S2, it is something else. Okay, explain how. Why the pain is there? Is the pain coming from skin or something else? That they cannot answer. Pain must be coming from skin. If it is coming from skin, then root value is S2 and the answer should be S2. So it is a controversial question, but remember, calf region and posterior thigh dermatome is S2. This diagram is from Harrison medicine. My answer is S2 and it is open to discussion. हमारी मातृभाषा में पढ़ा है, मातृभाषा तो हमारी हिंदी ही है। एनर्जेटिक तो इसलिए हैं क्योंकि 10वीं क्लास के बाद हमारी ज़िंदगी निशाचर, रात्रिचर, हम तो रात को ही एक्टिव रहते हैं। एमरजेंसी ड्यूटीज़ में मेरे को बहुत प्रेफर किया जाता था कि इसको बिठा दो, ये नहीं सोता। आई एम एक्टिव ओनली इन द नाइट, बट नॉट नेसेसरी। मेरा कोई डायरनल रिदम नहीं है, आई हैव नो डायरनल रिदम। जब मुझे आंखें भारी होती हैं तो सो जाता हूँ और 3 घंटे के बाद उठ जाता हूँ और फिर आंखें भारी होती हैं फिर सो जाता हूँ। मुझे ये नहीं पता होता कि रात है या दिन है, आई डोंट केयर। मेरा पिनियल ग्लैंड, मेलेटोनिन वगैरह, उसको कोई पता नहीं क्या हो रहा है क्योंकि कमरे तो बंद हैं, सूरज का तो कोई नामो निशान ही नहीं। बात खत्म हो गई। सूरज को देखोगे तभी तो पिनियल ग्लैंड कुछ करेगा, जब हमेशा ही अंधेरा है और हमेशा ही उजाला है। यहाँ पे कम से कम 25 लाइटें लगी हुई हैं, तो पिनियल सोच रहा होगा दिन ही हो गया है और क्या हो गया है, बंद कर दूं तो रात हो गई है, बंद कर दो तो सो जाओ, जला दो तो उठ जाओ। ओके, इस क्वेश्चन की बात कर रहे थे आप, तो आपको पता है आंसर क्या होगा। ऑर्थो के हिसाब से क्या आंसर होगा? ऑर्थो के हिसाब से आंसर तो L5 दे रहे हो, L5। ऑर्थो वाले L5 बता रहे हैं, मुझे समझ में नहीं आ रहा है L5 क्यों बता रहे हैं। कह रहे हैं शियाटिका है तो शियाटिक नर्व की रूट वैल्यू होती है L4-5 और स्लिप डिस्क जो है वो L5 पे ज़्यादा होता है। उनका लॉजिक ये है। ऑर्थो वाले कह रहे हैं कि पोस्टीरियर लेग में दर्द जरूर हो रही है, ठीक है मान लिया, मगर वो तो शियाटिका की पेन है और शियाटिक नर्व की 5 रूट वैल्यू होती हैं L4-5, S1-2-3, L4-5, S1-2-3। शियाटिक नर्व दबी है और शियाटिक नर्व में भी कौन सी रूट वैल्यू दबती है, वो इस तरह से कहे मोस्ट कॉमनली कौन सी दबती है, L5 दबती है या S1 दब जाती है, तो इसलिए दर्द हो रही है। मगर उनको ये पूछे कि ठीक है L5 S1 तो लिटिल टो में पेन होनी चाहिए ना, S1 लिटिल टो में बर्निंग सेंसेशन या पेन होनी चाहिए, ये लिटिल टो में लैटरल मार्जिन में पेन होनी चाहिए, ये बैक ऑफ लेग में क्यों हो रही है, बैक ऑफ थाई में क्यों हो रही है, वो तो S2 हो गया। यहां पे कंफ्यूजन है। आर्टरी थी मेरे ख्याल से, टेंडन नहीं थी, आर्टरी थी। और आर्टरी अगर आप कह रहे हो मीडियल मेलनस के पीछे, और ये है एफएमजी का क्वेश्चन। आप में से किसी ने पूछा था एफएमजी से लिया हुआ क्वेश्चन है ये। एफएमजी भी तो कौन कंडक्ट करता है, एनबीई वाले तो करते हैं, एनबीई वाले एफएमजी भी करते हैं, वहाँ से उठा लिया क्वेश्चन। तो ये जो आर्टरी है ये पोस्टीरियर टिबियल आर्टरी होगी। जब आपको बर्जर डिजीज़ की बात करते हैं, थ्रोम्बोएंजाइटिस ऑब्लिटरेंस, बर्जर डिजीज़, पेरिफेरल वास्कुलर डिजीज़, पल्स में प्रॉब्लम आ जाती है। सिगरेट स्मोकर 40 साल का, 40 साल का इंसान, सिगरेट स्मोकर, क्रॉनिक स्मोकर, and thromboangiitis obliterans, Berger disease, peripheral vascular disease, feel for the pulse is not there, and there is atherosclerosis and all that. Now, even if it was tendon, टेंडन के लिए आपके पास एक निमोनिक होता है. निमोनिक क्या है? टॉम, डिक एंड हैरी. योर निमोनिक इज टॉम, डिक एंड हैरी. ये you are looking at the flexor retinaculum, and flexor retinaculum which is attaching to medial malleus of the medial bone tibia, medial bone, medial malleus, from there to calcaneum bone is flexor retinaculum. Deep to flexor retinaculum you have these structures, Tom, Dick and Harry. T is tibialis posterior, because it is posterior to tibia, so tibialis posterior. This is from, you can say, anterior to posterior. You can say anterior to posterior. So T, Tom, is tibialis posterior. And what is D? Digitorum. Which digitorum? The one which will move the digits, toes. Yeah, but what movement? You will see these tendons, they come from the calf, and as they are coming from the calf, as they come from the calf, they will pull the toes, they will fold the toes. Fold the toes means flex, yes. Flexor digitorum longus, yes. Fold, flexion, folding. So they are coming from the calf, yes, and they will fold the toes. Flexor digitorum longus, yes. So flexor digitorum longus, yes. Then what is AN? Artery nerve. Which artery nerve? The artery nerve going behind tibia, so posterior tibial artery, posterior tibial nerve. Posterior tibial artery, posterior tibial nerve. Okay. Then what is this? Harry. Harry is hallucis. If you say Harry is hallucis, which hallucis is that? Coming from the calf, it will pull the thumb. Coming from the calf, it will pull the thumb. So what will happen if you pull the thumb? Flexion, flexion, flexor hallucis longus. Flexor hallucis longus, yes, flexor hallucis longus. They are all coming from calf. Calf is a flexor compartment. They are all coming from the calf, posterior leg, it is flexor compartment. Flexor hallucis, flexor digitorum, and tibialis posterior. So if you are telling between the medial malleus and Achilles tendon, Achilles tendon is attaching to calcaneum. Achilles tendon attaches to calcaneum. So between the two you have this artery, posterior tibial artery, or maybe if you ask about the tendon, the best answer will be tibialis posterior tendon. So that was your question. It will be posterior tibial artery, or if it was a tendon, then tibialis posterior tendon. Okay. Not audible? आवाज नहीं आ रही क्या? आवाज आ रही कि नहीं आ रही? प्रैक्टिस नहीं करते. प्रैक्टिस करने का समय कहाँ है? प्रैक्टिस करने का समय नहीं है. आ रही है ना? गुड. भाई इतना खर्चा करके सब किया हुआ है तो आवाज़ तो आनी चाहिए. बढ़िया कैमरा, बढ़िया टीवी, बढ़िया कंप्यूटर, बढ़िया फ़ोन, इसमें मैं कोई कसर नहीं छोड़ता. अब आवाज़ नहीं आएगी तो बड़े दुख की बात है. और गला भी, डॉक्टर संजय हैं ENT के, कहते हैं आपकी आवाज़ बड़ी बुलंद है. मैंने कहा टीचर की आवाज़ तो बुलंद ही होनी चाहिए. Okay, what about this? 35-year-old female and lesion. And so what is the lesion? You see, this is the pituitary tumor, and this is craniopharyngioma. Craniopharyngioma. You know, developmentally, at the roof of oral cavity, there is surface ectoderm that forms Rathke's pouch, and Rathke's pouch, during development, surface ectoderm at the roof of oral cavity will form the Rathke's pouch, and Rathke's pouch will form anterior pituitary or adeno hypophysis, and that can have tumor which is called craniopharyngioma. Now this surface ectoderm which goes from here to here passes nasopharynx. passes nasopharynx. So this tumor can start from nasopharynx into sphenoid bone. At the roof of oral cavity there is surface ectoderm, Rathke's pouch forms the anterior pituitary and it goes through the nasopharynx, reaches there. Adenohypophysis anterior pituitary is coming from Rathke's pouch and it can have this tumor craniopharyngioma in the sphenoid bone. It is a midline tumor, and because it is a midline tumor, tunnel vision, bitemporal hemianopia, because peripheral vision crosses in the optic chiasma, peripheral vision, temporal vision crosses in the optic chiasma which is midline. So pituitary tumor will compromise the optic chiasma, peripheral vision is gone, only nasal vision is there. It is called tunnel vision, bitemporal hemianopia. This is a case of bitemporal hemianopia. Let me show that now in this diagram also. You see, you have to understand that this is superior view of the individual, head towards you, feet away from you. This is superior view right eye, superior view left eye, right, left eye, right eye, left eye, superior view. Now look at the vision. You will see temporal vision crosses and goes to the other occipital visual cortex. Temporal vision crosses and goes to other occipital cortex. This vision is called as temporal vision or peripheral vision. This vision is temporal vision or peripheral vision. It crosses in the optic chiasma. You can show the same here as well. Left eye, temporal vision, nasal retina, optic chiasma, other sided occipital visual cortex. The temporal vision crosses. Right eye, temporal vision, right eye, temporal vision, nasal retina, cross in the optic chiasma and then goes to the other sided occipital visual cortex. If you have a tumor here, midline tumor at the optic chiasma, then peripheral vision is gone. If peripheral vision is gone, only nasal vision is working. And if only nasal vision is working, this is called bitemporal hemianopia. This is your case, bitemporal hemianopia. Otherwise, if you want to add some information, nasal vision is coming to temporal retina and goes ipsilaterally. Nasal vision right eye goes to temporal retina and goes to same sided brain. Right eye nasal vision goes to temporal retina and ipsilaterally goes to same brain. This may be not appearing clear to you. So nasal vision, temporal retina and going to same side of the brain. What will happen if I have a block here at the optic tract or block here at the optic radiation? If you have a block at the optic tract or optic radiation, it is right sided lesion, but left half of each eye will be blind. It is a right lesion, but you will see left half of each eye is blind. It is called as contralateral homonymous hemianopia. The lesion is on the right side, but the left half of each eye is blind. Left half of each eye is blind. Contralateral homonymous hemianopia. And if the lesion was at the level of occipital cortex like posterior cerebral artery right-sided blocked, right-sided posterior cerebral artery blocked. If right-sided posterior cerebral artery blocked, there will be macular sparing. Central vision is working. Why macular sparing? Because the additional supply of middle cerebral artery. It may happen a right-sided posterior cerebral artery blocked, occipital visual cortex gone. Same problem. Contralateral homonymous hemianopia. left half of each eye is blind, but with macular sparing. There is macular sparing. Why? Because maybe posterior cerebellar artery is gone, but middle cerebellar artery supply macular area on the brain. It is still working. That is why macular sparing. Okay, not going into much detail, but here your answer you can understand is, it's a midline tumor. Pituitary is in the midline. It's a midline tumor. So peripheral vision is gone. If peripheral vision is gone, you have tunnel vision. Bitemporal hemianopia. Kumar, after 20 years. Very good. यही तो मैंने कहा, लेक्चर के शुरू होते ही मैंने कहा आपको पीजी सीट भी मिल जाएगी ना, उसके बाद भी आप पढ़ते रहना, मेरे लेक्चर बीच बीच में कभी आके यूट्यूब में सुन लेना, आपको ज़रूर फ़ायदा करेंगे, क्योंकि ये आपकी ज़िंदगी भर साथ चलेंगे। ये सब जो चीज़ें हैं ना, ह्यूमन बॉडी की तो बात कर रहे हो, एनाटॉमी की बात कर रहे हो, और हम भूल जाते हैं, तो मैं आपको याद दिलाता रहूँगा। इसी तरह हमारा कनेक्शन भी बना रहेगा। ओके, ये क्या है? टेल मी। So this is, they are asking for diagnosis and some radiograph. Now you have to train your eyes, but before you train your eyes, you should read the options. Options: Enrol Now, Dandy Walker, Vein of Galen, Corpus callosum. ये दोनों तो वैसे ही हट गए, उन दोनों से कोई हो सकता है। Now, इनमें कैसे डिफरेंस करते हैं? You see, this is herniation of cerebellum into foramen magnum. Herniation of cerebellar tonsils into foramen magnum, leading to hydrocephalus. Hydrocephalus can be here, hydrocephalus can be here. Both the conditions can present with hydrocephalus, but there will be a difference. Enrol Now malformation, there is small posterior cranial fossa, one reason. So cerebellum is pushed down, or maybe there is some spinal cord tether syndrome. Spinal cord tether syndrome, spinal cord is pulled down. If you pull the spinal cord down, it will pull brainstem and cerebellum down. Tethered cord syndrome, maybe something wrong with the phylum terminal. So that can lead to Enrol Now malformation. Answer is Enrol Now malformation actually, but why not Dandy Walker? Because Dandy Walker can also present with hydrocephalus, but then I'll show you the difference. You can first see about this. This is the normal foramen magnum, and cerebellar tonsils may protrude slightly. You can see cerebellar tonsil in foramen magnum, it is normal, but it should not protrude too much. See here, 5 centimeter into foramen magnum, that is not good, and they'll have some problems. There'll be compression of brainstem also. So compression of brainstem like lower medulla, it is lower medulla which passes through foramen magnum. So lower medulla has vital centers, respiratory, cardiovascular centers, they'll be compressed. So Enrol Now malformation, and plus there'll be hydrocephalus. So this is Enrol Now. What about Dandy Walker? Dandy Walker is actually the other way around. In Dandy Walker, what happens is the cerebellum is small, and lot of CSF is accumulated in the fourth ventricle. The cerebellum itself is small. There is no herniation of cerebellum down here, and fourth ventricle becomes dilated with CSF, Dandy Walker, and hypoplasia of cerebellum may be one reason, hypoplasia of cerebellum, and it is also hydrocephalus, but this is Dandy Walker. It will be different appearance altogether. So in this question, the only possible answer is choice number A. सेकंड पेपर में हिस्टोलॉजी पूछा था, आंसर अभी आपको अभी हिस्टोलॉजी थोड़े आएंगे और भी. Let us move on to those questions as well. Okay, ये क्वेश्चन एक आप में से पूछ रहे थे. 40-year-old मेल है, डायबिटिक भी है और हाइपरटेंसिव भी है. डायबिटिक मेलाइटस, हाइपरटेंशन, और फिर सडन ऑनसेट वीकनेस राइट आर्म में हुई है, लेग में भी है, और एग्जामिनेशन में फेशियल पाल्सी भी है लेफ्ट साइड में, और निस्टैग्मस भी है, लेफ्ट आई में ही है. मतलब ये अगर पेशेंट है आपका, ये अगर पेशेंट है तो इस पेशेंट में क्या हुआ है कि लेफ्ट साइड का फेशियल पाल्सी है. ये फेशियल पाल्सी जो है वो लेफ्ट साइड में आई है, और इसके साथ ही साथ में लेफ्ट साइड में ही निस्टैग्मस भी है. और ये नहीं बताया कि वर्टिकल है या कि हॉरिजॉन्टल है. निस्टैग्मस वर्टिकल हॉरिजॉन्टल नहीं बताया, सिर्फ निस्टैग्मस बताया. और क्या है, राइट साइड में हेमीप्लेजिया है. मतलब राइट साइड में यहाँ पर क्या है, हेमीप्लेजिया. ये है हेमीप्लेजिया. अब आपसे पूछा जा रहा है कि क्या है ये, मिलर्ड गुबलर है, फोबिल है, वेबर तो नहीं है. क्यों? वेबर अगर होता तो थर्ड नर्व इन्वॉल्व होती, थर्ड नर्व मिड ब्रेन से आ रही होती, इन्वॉल्व होती, थर्ड नर्व तो इन्वॉल्व है नहीं, वेबर नहीं है. अच्छा, तो वेलेनबर्ग भी नहीं है. क्यों? क्योंकि इसमें तो न्यूक्लियस एम्बिगुअस इन्वॉल्व होता है 9, 10, 11, और पैलेट फेरिंक्स लैरिंक्स की मसल इन्वॉल्व होती, फेरिंक्स लैरिंक्स की मसल वो तो इन्वॉल्व है नहीं. डिफिकल्टी स्पीच फॉलोइंग तो नहीं बताया. तो वेबर इसलिए नहीं है कि थर्ड नर्व का कोई वो नहीं बताया नहीं है. और वेलेनबर्ग इसलिए नहीं है क्योंकि वेबर जो है वो मिड ब्रेन का लीजन होता है, अपर मिड ब्रेन, थर्ड नर्व के लेवल पे. और वेलेनबर्ग जो है वो मेडला ब्लॉन्गा था 9, 10, 11, तो कुछ ऐसा बताया नहीं. इन दोनों में से कोई है. पॉन्स में गड़बड़ है. आपने कैसे डिसाइड किया पॉन्स में गड़बड़ है? मैंने ऐसे डिसाइड किया पॉन्स में गड़बड़ है क्योंकि फेशियल नर्व का जो न्यूक्लियस है वो पॉन्स में होता है, नर्व भी पॉन्स में होती है. अच्छा, फेशियल नर्व इन्वॉल्व है इसलिए पॉन्स. हाँ, तो इनमें से कौन सा आंसर है? जब आप मिलर्ड गुबलर की बात कर रहे हैं या फोबिल की बात कर रहे हैं, फोबिल सिंड्रोम जो है, जैसे अब आप एक ट्रांसवर्स सेक्शन बनाइए, अब आप पॉन्स का ट्रांसवर्स सेक्शन. सो जब आप पॉन्स का एक ट्रांसवर्स सेक्शन बनाएंगे, समझ लीजिए ये एंटीरियर हो गया, ये पोस्टीरियर हो गया, ये मिड लाइन है, पॉन्स का आपने सेक्शन बनाया. आपको ये ध्यान होना चाहिए कि यहाँ पर आगे होता है पिरामिडल ट्रैक्ट. पिरामिडल ट्रैक्ट में भी कॉर्टिकोस्पाइनल ट्रैक्ट, और उसके लीजन से मान लीजिए अगर ये एंटीरियर है, ये पोस्टीरियर है, आपका पेशेंट, क्योंकि सीटी स्कैन हमेशा ऐसे लेते हैं, सीटी स्कैन हमेशा नीचे से ऊपर को देखते हैं, तो ये एंटीरियर, ये पोस्टीरियर, तो ये राइट साइड हो गया और ये लेफ्ट साइड हो गया, राइट लेफ्ट हो गया. ठीक है. अब फेशियल पाल्सी जो है वो लेफ्ट में है. फेशियल पाल्सी लेफ्ट में है तो इसमें लीजन भी लेफ्ट में ही होगा. यहां पर पिरामिडल ट्रैक्ट गया. अब पिरामिडल ट्रैक्ट अगर लेफ्ट में गया है पॉन्स में, तो कॉन्ट्रोलैटरल स्पैस्टिक पैरालिसिस होगी. यहां इस पेशेंट में मिलेगी कॉन्ट्रोलैटरल स्पैस्टिक पैरालिसिस, क्योंकि ये अपर मोटर न्यूरॉन लीजन है, पिरामिडल ट्रैक्ट का लीजन है. तो लेफ्ट साइड में इस पेशेंट को है लेफ्ट पॉन्टाइन सिंड्रोम. लेफ्ट साइड का पॉन्टाइन सिंड्रोम है. पिरामिडल ट्रैक्ट अगर लेफ्ट में जाए तो प्रॉब्लम आती है राइट साइड में, राइट कॉन्ट्रोलैटरल स्पैस्टिक पैरालिसिस होगी. लेकिन लेफ्ट की फेशियल पाल्सी क्यों होगी, लेफ्ट में निस्टैग्मस क्यों होगा? वो इसलिए है, आपको ध्यान रखना है कि यहां पर होता है 6 नर्व का न्यूक्लियस, एब्डुसेंट का न्यूक्लियस, और इसके साथ में आपको बताना है कि ये जो है 7th नर्व का न्यूक्लियस होता है, उसकी नर्व ऐसे घूम कर आगे जाती है. इसको मैं बना देता हूँ. ये 7th नर्व फेशियल नर्व का न्यूक्लियस है, घूम कर ऐसे जाती है, और जब क्योंकि वो घूम के जाती है यहाँ इंटरनल जेन्यू बनता है, और इंटरनल जेन्यू के कारण ही यहाँ पर पीछे की तरफ फेशियल कॉलिकुलस भी बनता है, फेशियल कॉलिकुलस. तो ये है पीछे की तरफ फेशियल कॉलिकुलस, उसके ऊपर हमें ध्यान नहीं देना. बट 6th nucleus is there and 7th nerve is coming out from here. Now this is on the right side, problem was on the left side. So let us show it on the left side also. Left side This is facial nucleus, that is the nerve going out. This is the facial nucleus and that is the nerve going out. But then 6th nerve is also going out. So 6th nerve was also going out. 6th is more medial, 7th is more lateral, but both are lateral to pyramidal tract at the base of the pons, at the anterior side of pons. So at the base of the pons, anterior side of the pons, you have the pyramidal tract, and lateral to that will be the number 6 and 7. 6 is medial, 7 is lateral. Okay, so where all is the problem? Problem is, actually this is a case of Fauvel syndrome. Answer is Fauvel syndrome. Why Fauvel? Because in Fauvel syndrome, the problem is here, here and here. But medial pontine syndrome. We call it as medial pontine. But why would you say medial? It is medial because these nerves are having nuclei medial and this pyramidal tract is medial near the midline. That is why it is medial pontine syndrome. Okay, so you are telling lower motor neuron lesion of nerve 6, 7. Yes, these are lower motor neurons only. Nerves, what is nerve? Lower motor neuron. So lower motor neuron lesion of 6 and 7, yes. So why there is nystagmus? There is nystagmus because see, this is element palsy. Facial palsy is element palsy. That is why it is involving upper face and lower face. Upper face, lower face both are involved. It is element type of facial palsy like Bell's palsy. The facial nerve is involved. Okay, fine, but why nystagmus? Nystagmus because this is 6th nerve nucleus. PPRF is compromised. What is PPRF? Para-pontine reticular formation is compromised. You are telling left-sided PPRF compromised? Yes. What does it do? The 6th nucleus using PPRF sends information to the 3rd nucleus on the other side of the midbrain by a MLF, medial longitudinal fascicle. So little bit detailed, but 6th nucleus on the left uses PPRF to cross the midline, send the MLF to the 3rd nerve nucleus on the right side. You are trying to say 6th nerve works with 3rd nerve. For what purpose? 6th nerve is working with 3rd nerve for what purpose? Lateral gaze, lateral gaze, lateral gaze. So if you want to have a good lateral gaze, one-sided lateral rectus will work 6th nerve, other sided medial rectus will work 3rd nerve. 6th nerve, 3rd nerve, they should work together. And that is why if you have a Fauvel syndrome, this PPRF is also gone. 6th nucleus is gone, PPRF is gone. And that is why there is nystagmus. And this nystagmus will be horizontal gaze, not vertical. This will be horizontal gaze, not vertical. Vertical you will see if it was Weber syndrome. In Weber syndrome, not Weber actually, it will be Perinod syndrome, Perinod. If you have Perinod syndrome, you will have vertical gaze nystagmus. Midbrain, posterior, Perinod syndrome, midbrain, posterior, Perinod syndrome, you will have vertical gaze. But this is not a problem of vertical gaze anyway, it is a problem of horizontal gaze. So I hope you got the point. Then why not the Fauvel's, why not the Miller-Goubert? Miller-Goubert, if you say, it is not entire thing. It is not entire thing. In Miller-Goubert, only ventral area is involved. So no nystagmus will be there. Only 6th nerve, 7th nerve, pyramidal tract will be involved. You are telling that it cannot be Miller-Goubert? No. Why it cannot be Miller-Goubert? Because it is more ventral. Okay, if it is ventral, then it will not be involving this PPRF and all that. No. No nystagmus? No. Then what will be there? Everything else, contralateral spastic paralysis, facial nerve palsy, lateral rectus palsy, lateral rectus palsy, facial palsy, everything will be same except for nystagmus. If nystagmus is there, Fauvel. If nystagmus is not there, then maybe it is Miller-Goubert. Lateral gaze palsy was there. Yeah, it can be. In Miller-Goubert, lateral gaze palsy will be there because 6th nerve is gone. but nystagmus will not be there, because for nystagmus you must involve this PPRF and MLF thing, and that will happen only in fobil. So, too much of neuroanatomy here, but I thought we should discuss. Okay, what about this question? What about this question? See, lateral gaze palsy can be in both the syndrome, in fobil as well as Miller-Goodall, but in fobil you will have nystagmus also. The question has already mentioned nystagmus. Sixth nerve will be involved in both of them, obviously. Element type of palsy will be there. Okay, so this is about that we told greater auricular nerve supply greater part of auricle, because it supply greater part of auricle, that is why greater auricular nerve. Now, say you are doing ear piercing. When you do ear piercing, greater auricular nerve on the lateral side, greater auricular nerve on the medial side also will carry the pain. So, if you are doing the ear piercing, here the nerve is greater auricular nerve, greater auricular nerve. Okay, but be careful, greater auricular, but here it is lesser occipital bone, lesser occipital nerve, occipital bone, lesser occipital nerve. If I do the ear piercing here, two nerves will carry the pain. Which two nerves? Laterally it is greater auricular nerve, but medially it will be lesser occipital nerve. Let me show the lesser occipital nerve now. So, here it is the lesser occipital nerve. So, you mean to say D is lesser occipital nerve? Yes. And B is greater auricular nerve? Yes. This B is greater auricular nerve? Yes. What if I do the ear piercing in the tragus, auricular temporal nerve, auricular temporal nerve. So, that is auricular temporal nerve? Yes. This is A is auricular temporal nerve. Tragus. Nobody does any ear piercing here, but people don't, you don't know people, they might. So, auricular temporal nerve. Then what is this? Here you know auricular branch of vagus carried by the axons of facial nerve. Auricular branch of vagus, annulled nerve carried by vagus. So, you are telling external auditory meatus. Yes, external auditory meatus, auricular branch of vagus carried by facial nerve. Yes. What is this auricular branch of vagus carried by facial nerve? What does that mean? That means vagus do not come here. Vagus is a visceral nerve usually. Vagus will not come here, but vagus will send axons via facial nerve, because facial nerve was going here. The vagus nerve is asking facial nerve, yes. You are going to the ear, yes. Take few axons, okay, give it to me, and it will carry here. What is the importance? Importance is, you know, when you put some, you are doing ear syringing. When you do ear syringing, there is a chance of vasovagal syncope. Why? Because when you do ear syringing, the vasovagal syncope, because you are activating the vagus nerve. External auditory opening plus the floor of the external auditory canal also. Anterior wall and floor of external auditory canal. So, external auditory canal, anterior and floor is by auricular branch of vagus and annulled nerve. Yes. Be careful when you do ear syringing, you might lead to vasovagal syncope. Okay, what is the role of facial nerve here? A role of facial nerve is, if you cut the facial nerve, sensory loss here. If you cut the facial nerve, say somewhere in the middle ear you cut the facial nerve. If in the middle ear you cut the facial nerve, there will be sensory loss. Now, somebody might think this area is supplied by vagus, why there is sensory loss by cutting facial nerve? Because when you cut the facial nerve, you have cut the few axons of vagus also. That is why we say this area is supplied by auricular branch of vagus carried by the branches of facial nerve. Because if you damage facial nerve, vagus nerve is also gone. So, answer is evident to you, it is already here. Number one is A is auriculotemporal nerve, B is greater auricular nerve, C is vagus, of course you say vagus but carried by branches of facial, and D is lesser occipital nerve. Occipital bone, lesser occipital nerve. If you want a complete diagram, it is here. I think it is ENT Dhingra diagram. This lady has piercing here, this lady has piercing here, she has piercing here also, she can have piercing here also. Which nerve will carry the pain? Here greater auricular nerve, there greater auricular nerve plus lesser occipital nerve, and here auriculotemporal nerve. And what if she puts a pencil here inside auricular branch of vagus and all nerve carried by axons of facial nerve. 7 and 10, 7 and 10, ENT Dhingra. So your questions are, you cannot depend only on anatomy, that okay I will do anatomy, I will read anatomy and my anatomy will be taken care of. No, anatomy plus ENT, anatomy plus orthopedics, anatomy plus anesthesia, anatomy plus orthopedics, anatomy plus OBG, anatomy plus pediatrics, anatomy plus medicine, anatomy plus surgery, anatomy plus physiology, anatomy plus pathology. Of course you cannot mix anatomy plus biochemistry, anatomy plus microbiology, anatomy plus PSM, it will be a very bad combination, but anatomy is almost in 12 of the 19 subjects, cannot escape anatomy. And nobody is asking anatomy actually, they are asking anatomy plus something, interdisciplinary, clinical questions. Okay, patient, all the time patient, patient, patient. So, patient with sciatica had tender hamstrings. Now, which muscle is hybrid? Lateral gaze palsy was there. Okay, you already asked that, I answered. You have to understand, when you take a transverse section, say right thigh transverse section, you have anterior, medial and posterior thigh, anterior, medial and posterior thigh. This is anterior thigh muscles supplied by the femoral nerve, anterior thigh muscles supplied by femoral nerve, like you have quadriceps femoris, quadriceps femoris. Then you have the medial thigh muscles, medial thigh muscles, adductor muscles supplied by obturator nerve. So these are adductor muscles and they are supplied by obturator nerve. You can show the nerve here. Say this is going to be the obturator nerve. And then you have the hamstrings posteriorly, and these hamstrings will be supplied by tibial part of sciatic nerve. The hamstrings are basically long head of biceps femoris, semitendinosus, semimembranosus, these are hamstrings to be supplied by tibial part of sciatic nerve, tibial sciatic nerve. But now you see there is a boundary line muscle, you see this boundary line muscle, and this boundary line muscle, which let me mark it here, this boundary line muscle is adductor magnus. Adductor magnus has anterior adductor part and posterior hamstring part. It is a hybrid muscle, it has two nerve supply. The medial part, adductor part supplied by obturator nerve, and posterior hamstring part supplied by tibial sciatic. It is a hybrid muscle. So adductor magnus is a boundary line muscle between medial thigh and posterior thigh. Part of it is adductor, part of it is hamstring. Hamstring supplied by tibial sciatic, adductor supplied by the obturator nerve. And if there is a problem of hamstring, the hamstring part may be involved, tibial sciatic part will be involved, but the adductor part will be spared. Obturator nerve is your answer. Question was, which part was spared? Adductor part. And which nerve? Obturator nerve. That is why in this question, your answer will be the obturator nerve supplying the adductor part of adductor magnus. That will be spared. It is a hybrid muscle having more than one nerve supply. And what about hamstring? Hamstrings, they are supplied by tibial part of sciatic nerve. Tibial part of sciatic nerve. So they have been compromised. But still adductor part is working. Your answer is choice number C. If we cut the nerve at geniculate ganglion, then what will be effect on taste sensation, palate and nose, palate. Okay. If we cut the facial nerve at the geniculate ganglion, then the effect will be taste sensation will be lost not only from tongue but also from palate, because both of them carry the information to geniculate ganglion. You have cut it proximal to that. So, taste sensation from tongue, chorda tympani nerve, taste sensation from palate, greater petrosal nerve, both of them carry to geniculate ganglion, but you have cut the nerve proximal to geniculate ganglion. So, those sensation will be lost. That is point 1. Yeah, that is what you are asking. And if you cut the facial nerve proximal to that, then all the glands on the face, the L, NP gland, lacrimal, nasal, palatine and sublingual, submandibular gland, all the 5 face glands will be supplied to facial nerve compromised, because you cut the facial nerve proximal to geniculate ganglion. The fibers, greater petrosal nerve, LNP gland and the chorda tympani nerve, sublingual, submandibular gland, they will not work. So, face will become dry, eye is dry, nose is dry, palate is dry, mouth is dry, though parotid will work, but still decrease saliva. This is feature of facial nerve palsy if you cut facial nerve proximal to geniculate ganglion. FMGE के लिए रैपिड रिवीजन काफ़ी है क्योंकि 50% नंबर लेने होते हैं. FMGE के लिए रैपिड रिवीजन काफ़ी है क्योंकि आपको सिर्फ 50% नंबर लेने होते हैं. लेकिन एक मैं बात कहूँगा कि मॉक टेस्ट देते रहिए और ग्रैंड टेस्ट देते रहिए, और जो LRR होता है, लास्ट रिजॉर्ट रिवीजन होता है, उसको देखते रहिए, क्योंकि नए क्वेश्चन कई बार रैपिड रिवीजन में इंक्लूडेड नहीं होते, क्यों नए आ गए हैं तो रैपिड रिवीजन तो पहले बना होता है कई बार. तो मॉक टेस्ट, ग्रैंड टेस्ट, LRR ये साथ में देखते रहिए. बाकी रैपिड रिवीजन इज़ गुड फॉर FMGE की बात कर रहे हो. ऑल इंडिया PG क्लियर नहीं कर सकते, लेकिन ऑल इंडिया PG के लिए आपको मेन वीडियो देखने पड़ेंगे. ओके, अब इसके अलावा जो है कंजेनाइटल डायफ्रैग्मेटिक हर्निया, CDH. कंजेनाइटल डायफ्रैग्मेटिक हर्निया की अगर आप बात कर रहे हैं तो उसके लिए आप एक डायग्राम देख लीजिए, और जब वो डायग्राम आप देख रहे हैं तो आपको ये समझना है कि इंफीरियर टू सुपीरियर है, ये इंफीरियर टू सुपीरियर डायफ्राम का डेवलपमेंट हो रहा है. इंफीरियर टू सुपीरियर डायफ्राम का डेवलपमेंट हो रहा है, ये फ्रंट व्यू से है. ये फ्रंट व्यू से यहाँ पे कंजेनाइटल डायफ्रैग्मेटिक हर्निया हो गया. डायफ्राम में एक ओपनिंग आ गई है, एंड through that opening you see the intestine has moved into left thorax and there is a dextrocardia. The intestine is pushing the heart to right side. So there is a congenital diaphragmatic hernia. Intestine has moved into left thoracic cavity, pushing the medial sternum to right side, dextrocardia kind of appearance. So what is the defect in? Defect is basically in this part of the developing diaphragm, which is called as the left-sided pleuroperitoneal membrane. Normally the pleuroperitoneal membrane will separate pleural cavity from peritoneal cavity and contribute to diaphragm. Normally this membrane separates pleural cavity from peritoneal cavity and contributes to diaphragm, and it may be missing mostly on left side, and left posterolateral Bochdelic hernia. So most common type of congenital diaphragmatic hernia is Bochdelic hernia. Most common type of congenital diaphragmatic hernia is Bochdelic hernia. It is due to deficiency of left pleuroperitoneal membrane, and it is posterolateral defect in the diaphragm. Posterolateral defect in the diaphragm. Now, to discuss the same thing, you can look from inferior to superior. You will see this membrane on the left side is missing. This membrane is missing, which is basically pleuroperitoneal membrane, and that too left side. That is what the examiner was asking. So this Bochdelic congenital diaphragmatic hernia is mostly on the left side, postero and lateral. Exactly opposite, right anteromedial, is Morgagni hernia. right anterior medial, exactly opposite. So Bochdelic hernia exactly opposite, right anterior medial, and that is left posterolateral. So this is left posterolateral, exactly opposite is right anterior medial, and that will be Morgagni. But Morgagni hernia is very rare. Morgagni hernia is very rare. Morgagni hernia will be on the right side, anterior and near the midline. Here, some transverse colon will go behind sternum. Some transverse colon will go behind sternum. That will be Morgagni hernia. It's very rare type of hernia, but it is right, that was left. This is anterior, that was posterior. This is medial, that was lateral. So Bochdelic hernia is more common, and it is left posterolateral due to deficiency of left-sided pleuroperitoneal membrane, herniation of intestine into the left thoracic cavity, pushing the mediastinum to right side, right mediastinum shift, and these patients will have difficulty breathing, cyanosis at birth, difficulty breathing, cyanosis at birth. So as you see, if they are asking, most common site for congenital diaphragmatic hernia is Bochdelic hernia, and if it is Bochdelic hernia, it is left posterolateral, left posterolateral, Bochdelic hernia, that is your answer. And if it is antero, others are, you can discuss, but this is your answer. Okay, what about this question? Sensation 3.5 fingers. Patient lost lateral 3.5 fingers and thenar atrophy. Thenar atrophy means median nerve. There is nothing much to discuss if they have given thenar atrophy. If they have not given thenar atrophy, 3.5 fingers can be radial nerve also, radial nerve. It can be radial nerve also because dorsum 3.5 finger is radial nerve, but they have given the thenar atrophy, the median nerve. If this was the question. Now you will say, why not anterior-introitious? Anterior-introitious nerve cannot be the answer because it is a pure motor nerve. It is a pure motor nerve and you are having some sensory problem, so cannot be the answer. It is a pure motor nerve, it supply 2.5 muscles, the FDP, FPL and pronator quadratus. This nerve supply 3 muscles, and the muscles which it supply are, anterior-introitious nerve is a branch of median nerve, it is a branch of median nerve, and it supplies 2.5 muscle, the lateral half of flexor digitorum profundus, then it is supplying the flexor pollicis longus, flexor pollicis longus, they are all in the anterior forearm, and then it is pronator quadratus. So this cannot be an answer because it is a pure motor nerve, your patient is having sensory problem, and this is a nerve of the anterior forearm, deep muscles in the anterior forearm. So what are the deep muscles in the anterior forearm? Lateral half of FDP, these 2 fingers, DIP joint flexion. DIP joint flexion, if you want to do the DIP joint flexion here, you will have to use the lateral half of FDP and flexor pollicis longus. You see, if this nerve is gone, then you cannot make the OK sign. OK sign will be gone. What is OK sign? OK. You cannot flex the thumb, you cannot flex the index finger. Why cannot flex the thumb? Because if anterior-introitious nerve is gone, you cannot use flexor pollicis longus, and if anterior-introitious nerve is gone, you cannot use the FDP of index finger, distal IP. So you cannot make the OK sign. In anterior-introitious nerve injury, it will be like this. But why it cannot be like this? I told you, FPL is not working, FDP is not working. Then how can you do this? Because you have short muscles, these are long muscles. You can use the short muscles like opponents, flexor, abductor. You can use the opponents pollicis, flexor pollicis brevis, the abductor pollicis brevis, adductor pollicis brevis, adductor pollicis, you can use them. You can do this, but you cannot do this if it was anterior-introitious. So anyway, it is median nerve. Now if that is your answer, fine. What about this question? Now tell me, what is the answer? So as you can see, this question is asking about a patient who has nerve injury make O with index finger and thumb. OK sign. OK sign. Was unable to do so. Now, which muscle is involved? You will see none of the three are given, or none of the two are given. FPL is not given and FDP is also not given. FPL is not given and FDP is not given. So, which one will you choose? Patient with nerve injury was asked to make O and he is not able to do. So, which muscle is not working? This type of question came earlier also. You have to understand here some muscles are hybrid. Some muscles are hybrid. And which muscles are hybrid? You should know, according to Gray's anatomy, opponent's pollicis is supplied by median nerve plus ulnar nerve. So, it is hybrid. The flexor pollicis brevis is supplied by median nerve plus ulnar nerve. So, it is hybrid. The deep part is by deep branch of ulnar nerve supply deep part. So, deep branch of ulnar nerve supply deep part. So, palmar introsia anyway is not to be considered. So, are you trying to say that the best possible answer appears to be B? Yes, because it is purely supplied by median nerve. It is purely supplied by median nerve. So, you are trying to say that it was a median nerve injury. Yes, because with the nerve injury, nerve injury, it is a single nerve, it is not multiple nerve. Okay. So, you are telling median nerve was gone, yes. But if abductor is not working, what is it has to do with making a 0, making a OK? It is very simple. First you have to do abduction, then only you can do this. If abduction is not having, it is called ape thumb deformity. If median nerve is gone, abductor is not working, it will be ape thumb deformity. With ape thumb deformity, you cannot make the 0 despite the fact that your flexor pollicis longus is working, your FDP is working, maybe your abductor, this flexor pollicis longus is working, maybe FDP is working, maybe they are okay because nerve is injured somewhere here. Carpal tunnel syndrome, median nerve gone. In carpal tunnel syndrome, median nerve is gone, you cannot make one O. Why cannot make O? To make O, I have to use these muscles. Yeah, maybe. But to do this, first you have to do abduction, and that abduction is done by only one muscle. This is called anterior abduction. Anterior abduction, palmar abduction. Anterior abduction, palmar abduction is done by only one muscle. It is a muscle of the abductor pollicis brevis, supplied only by median nerve. If median nerve is gone in carpal tunnel syndrome, you cannot use it, there will be ape thumb deformity. And when there is ape thumb deformity, despite the fact that the flexor pollicis longus and flexor distal profundus are working, you cannot make an. So, you are telling that the answer is choice number B. Yes, it is, and challenge me anytime, because I know some orthopedician is going to challenge me, but I will stick to my principles, because maybe orthopedician they do not read anatomy, but I definitely read orthopedics. So, you decide who is better. This type of epithelium seen where? Can you see one thing here? This is a this appears to be a multi-layered epithelium, appears to be multi-layered because nuclei at multiple levels, but it is not stratified. Why it is not stratified? Because each cell touches the basement membrane. Each cell touches the basement membrane. Because each cell touches the basement membrane, this cannot be stratified. So, it is not stratified? No. Each cell touches the basement membrane? Yes. What epithelium is this? Pseudo-stratified? No. Then what it is? Look at the topmost cell. As you look at the topmost cell, you will find these cells are so large and globular, They are so large that they appear like an umbrella shaped cells. and under that you can see 3-4 other cells. So, umbrella cells you can say, and under that you have 3-4 cells. Here is the rain, the urine. Urine is the rain of urine, and there is umbrella cell, 3-4 cells under that umbrella. So, that umbrella cell is transitional epithelium. Preventing these cells from rain of urine, you can just put an analogy. This is transitional epithelium. If this is transitional epithelium, ureter, yes, ureter, urinary bladder or proximal urethra. Ureter, urinary bladder or proximal urethra. You have transitional epithelium. So, A is the answer. Yes, it is. What about this alcoholic patient, RTA and all that? In this question there is one simple thing which is given which will help you reach your answer. Alcoholic, if you say anterior lobe of cerebellum is gone, and these people walk with drunken gait. Drunken gait means wide waist gait. You must have seen people who are drunk, they walk with a wide waist gait so that they do not fall. They feel that they will fall, that is why. Alcoholic patient, anterior lobe of cerebellum is compromised, drunken gait, wide base gait, but be careful. It can also be seen in flocculonodular lobe. This is your answer. Why this is the answer? Why this is not the answer? Because they have given nystagmus. That is why. In anterior lobe, you will not have nystagmus, but in flocculonodular lobe, which is the oldest of cerebellum, you will have nystagmus. That is why A is the answer. When we think of a drunkard, we say anterior lobe syndrome, maybe. But that gait is also seen in flocculonodular lobe. Flocculonodular lobe is the oldest of cerebellum, and it relates with the vestibular system, balance. Vestibular system, 8th nerve, vestibulocochlear nerve, vestibular nerve. So, oldest of cerebellum, which is archicerebellum, you call it as archicerebellum. If you look at the nucleus, it will be Fastigi nucleus, which came from fish. It came from fish. We were fish some time back. First we were fish, then we became amphibian reptiles, now we are mammals. And to make you appreciate that, you have this thing here. What I am telling is, in evolution, first we were fish, and fish we got fastigial nucleus. Then we became amphibian reptiles. Amphibian reptiles, these nucleus were coming interposed. Who is interposed? It is the emboliform and globose, and now we are mammal. Lateral most latest. is latest. So, lateral most is latest. Who is that? Dentate nucleus. Dentate nucleus is lateral most, and it is the latest in evolution. And what is it for? Fine finger movement. Like I am writing with the help of my dentate nucleus. So, oldest brain, new brain added. Oldest brain, small brain is fish brain. We became amphibian reptiles, more brain. Then we became mammals, more brain. Lateral is latest and fine movement, distal movements. You mean to say the amphibians proximal muscles like shoulder muscle, gluteal muscles? Yes. And fish, axial muscle like erector spinae? Yes. Axial muscle, erector spinae, fish. Amphibians, proximal muscles, shoulder muscle and gluteal muscles. And what about finger muscles? Lumbrical interossei? They are latest, fine movement, dentate nucleus, lateral most. So, you can see this is archicerebellum, oldest, flocculonodular lobe, nucleus fastigi coming from fish, vestibular nerve, vestibular maintenance of equilibrium, axial position, axial balance. This was the problem of the patient. Otherwise, if you talk about the paleo, which is the reptiles, amphibians, anterior lobe you can consider, nucleus interpositus, that is globose and emboliform, spinocerebellar, it connects with spinal cord, and then controls crude movement like shoulder movement, crude movement. And what about the fine movement? If you say fine movement, then you can come here, neocerebellum, most recent evolution, posterior lobe, nucleus dentate, lateral most latest. This is CPC fiber, CPC, corticopontocerebellar, latest cerebellum, and this is for smooth performance of something like writing. As I am writing, I use my corticopontocerebellar pathway, CPC pathway. This is the latest cerebellum in evolution. But question was on nystagmus. Nystagmus has something to do with the 8th nerve, vestibular. Vestibular means flocculonodular lobe, the oldest cerebellum. That is why in this question your answer remains choice number A, because they have given nystagmus. Otherwise I could have thought of anterior lobe, because alcoholic people, their anterior lobe is gone. Okay, what is this we are doing? What is this we are doing? You have got, and you should not be surprised, whatever I have discussed in this session, this is the last question, everything is there in the main videos. If somebody comes and tells me, सर आप पढ़ाते हो उसमें से तो कुछ आता ही नहीं है, तो मेरा सवाल ये होता है कि क्या आपने मेरे मेन वीडियोस से पढ़ाई करी थी? यहाँ पर फ़र्क आ जा रहा है. आप अगर पूछते हो कि रैपिड रिवीजन से काम चल जाएगा, नहीं चलेगा. एफएमजी के बच्चे हो चल जाएगा, लेकिन पीजी में एग्ज़ाम आप नहीं क्लियर कर सकते. अच्छे रैंक से क्लियर तो कर ही सकते हो, अच्छा रैंक नहीं आएगा, और INI-CT में तो और मुश्किल हो जाता है. ये सारी चीज़ें, ये स्लाइड्स मेरे अपने मेन वीडियोस से उठाई हुई हैं. अब कोई मुझसे पूछेगा कि भाई तुम तो एनाटॉमी के बंदे हो, ये लैचमैन टेस्ट क्यों पढ़ा रहे हो? तुम तो एनाटॉमी के बंदे हो, लैचमैन टेस्ट क्यों पढ़ा रहे हो? ये तो मैं पिछले 15 साल से पढ़ा रहा हूँ, ये सोचकर कि कभी ना कभी तो पूछ ही लेंगे, और पूछते रहते हैं. अच्छा लैचमैन टेस्ट है, हाँ हाँ वही है. ओके, कैसे पता चला? क्योंकि आपने सुपाइन पोस्चर रखा हुआ 20 डिग्री, 15 से 20 डिग्री का नी फ्लेक्शन है, 15 से 20 डिग्री. अगर ये एंटीरियर ड्रॉयर होता तो 90 डिग्री का होता. एंटीरियर ड्रॉयर के लिए आपको 90 डिग्री में बेंड करना होता है. किसको? नी फ्लेक्शन. ये आपने 15 से 20 दिया, ये लेस पेनफुल होता है. लैचमैन टेस्ट आंसर है हाँ. क्या चेक करने की कोशिश कर रहे हो कि ACL तो नहीं टीयर, ACL टीयर तो नहीं है, क्योंकि ट्विस्टिंग फॉल है. ये फुटबॉल प्लेयर, खासकर रग्बी प्लेयर जो होते हैं, अमेरिकन फुटबॉल, जो अमेरिकन फुटबॉल होती है, रग्बी प्लेयर होते हैं, इनके ट्विस्टिंग फॉल जब भी आपसे कह रहे हैं, ये टेरिबल ट्रायड की बात कर रहे हैं. टेरिबल ट्रायड क्या मतलब? 3 चीज़ें. हाँ, क्या 3 चीज़ें? ACL जो जुड़ी होती है मीडियल मेनिस्कस से, और टिबियल कोलैटरल लिगामेंट, ये तीनों चली जाती हैं, और इसके लिए आप टेस्ट कर रहे हो. ACL, मीडियल मेनिस्कल इंजरी एंड टिबियल कोलैटरल लिगामेंट इंजरी, हाँ ये है टेरिबल ट्रायड. इनमें से आप ACL को कर रहे हो, ये टिबिया को आगे खींचने की कोशिश कर रहे हो कि टिबिया आगे तो नहीं आ रही कहीं, क्योंकि अगर ACL टीयर है, इफ़ यू हैव ACL टीयर, देन normally ACL prevent anterior displacement of tibia. Normally ACL prevents, पहले तो आपको ये बोलना चाहिए जब भी ACL पूछा जाए ना, all the time tell ACL prevents posterior displacement of femur. PDF सर PDF फाइल देना, PDF फाइल देना, PDF निमोनिक हो गया. ACL prevents posterior displacement of femur and anterior displacement of tibia. So what is the function of ACL? Prevent the 2 bones going from each other, away from each other. Which 2 bones are going away from each other? Femur and tibia. So what is ACL doing? PDF. What is PDF? ACL prevents posterior displacement of femur and also anterior displacement of tibia. So what are you trying to do right now? Right now I fix the femur and pull the tibia anterior. Try to pull the tibia anterior. You cannot pull the tibia anterior because it is prevented by ACL. But if you can pull the tibia anterior, that means Latchman test has become positive. But why do you do Latchman test? Why don't you do anterior drawer test? I do Latchman test because it is less painful than the anterior drawer test done at 15 to 20 degree knee flexion, plus it has high specificity and high sensitivity, which is in PSM it is very rare. PSM, how many tests do you have where high sensitivity and high specificity is there? One compromises the other. If you are talking about AIDS, you will have the screening test, ELISA, and if you have the specificity, Western blot, then you will lose something. But this is a test which has high specificity and high sensitivity, which is a good thing. So why not do Latchman, which is less painful also, and class is also over, so that the pain which you were going through, the torture which I am doing right now is also over. Okay, so that was the last question I wanted to take care of, and only 15 students are left which doesn't matter, because I will teach only one student. Only if the one student is sitting there, I will teach that one student only. That is my nature, does not matter. I have taught 1800 students also. So I think once I taught some 3300, not 30,000, 3300 students sitting in an auditorium. So I can take care of 3300 students, 3300 plus students. It was Talcotara Stadium, and I can take care of 3 students also with same energy, as somebody told, with same energy, does not matter. Okay, so now what I understand is that most of you who are watching this have already given the exam, and it is my sincere wish, I trust that whatever you have done, it will bring good result to you, and I will find you at some good place, good college, good branch in the coming times. My wishes are always with you, and live long and prosper, like they say, live long and prosper. Okay, good night, take care, bye bye.